Is there any chance you'll be able to switch your camera off, Mr. Wellham? Mr. Wellham? Would there be any chance, Mr. Wellham, be able to switch your camera off for the meeting? And if you speak, switch back on again. Okay, well, I'm going to start anyway. So welcome, everybody, to this Health and Wellbeing Board meeting. I think I've realised I always ask people to introduce themselves when they speak so people know who they are. And I think I always fail to introduce myself. So I'm Graham Hoskin, I'm chair of this board, and I'm Reading's lead counsellor for health, wellbeing and sport. I'm going to start with the chair's announcement. If you've had any of these meetings online, you'll have heard all of this before, but I'm going to read it all out. So I'd like to inform everyone present that this meeting will be recorded in Microsoft Teams and will then be uploaded and available for repeat viewing on the council's website. Councillors, officers and partners attending will be asked to introduce themselves before they speak at the meeting for the benefit of the public and each other, I think, really. To help me manage the meeting, if any members of the board wish to speak during the meeting, please can you indicate your wish to speak in the chat section of the screen and then wait to be called. And that's really helpful for understanding the order of who has indicated and making sure we can see that. When not speaking, if all attendees could put the microphones on mute and switch off their cameras. When called to speak, please switch on your camera, unmute your microphone, pause for about 3 seconds to allow for the slight time delay in connection. If you're addressing the meeting, it would be best if you can have your camera on so that people can see who's speaking. However, we are aware that we're at the mercy of individuals' broadband services, so it is possible that loss of connection may happen. Or if your connection is poor, you may find that it improves if you turn your camera off, so we'll understand if that is necessary. So thank you for all that. Everyone's memorised all of that. So as I say, welcome again. Before we start, I do have one announcement, which I'll forget if I leave it to the end, and that is to basically to thank David Munday for his service to the board and to the council and to the people of Reading, because unfortunately he's leaving us at the end of the month to go to pastures new. I don't know if that's allowed to say where it is, but it's very much closer to where he lives, and it's just north of the border of Reading. So I can understand. I think obviously terrible mistake, David, to be leaving us to go to a county council, but I understand the reasons. And good luck with your new job, and thank you very much for all you've done.
Thank you, Chair. That's very kind.
Right. Okay. First item, Nikki. So the first item is declarations of interest. So if anyone has a declaration of interest, mention that now. If it occurs to you during the meeting whether an agenda item comes up, then obviously it'll be better late than never and declare it at that point. It's never on the agenda, but I always ask Nikki, what apologies do we have?
Yes, Chair. So I've had apologies from David Shepherd, from Health Watch, from Teresa Bell, and from Shona, and Merridin's going to be late.
Great, thank you, Nikki.
So any other colleagues have any?
Yeah. So does anyone else have any apologies? I realise I haven't got my chat displaying, but I'll make sure I do that now. But I don't think we have any other apologies. Okay, great. On to the first item, which is minutes of the meeting held on 19th March. Hopefully everyone's had a chance to look at those. They're pages 5 to 14 of your reports pack. I don't intend to go through them page by page. Has anybody got anything that they need to raise on a matter on them or on accuracy? If you indicate now, because if no one indicates, will be that everyone's happy and we'll sign those off as a true record. Okay, I don't see anyone indicating, so we'll sign those off as a true record. Thank you. So the next item is questions. We've got a question from a member of the public, Mr. Tom Lake. I know you're there somewhere, Tom, and I better find my answer to your question, hadn't I? But if you would like to ask your question, Tom.
Thank you. So I'm Information Officer of South Reading Patient Voice. Last November and December, South Reading Patient Voice carried out a survey of the experiences of older patients with regard to new electronic forms of access to GP surgeries. And can I just add our gratitude to Reading Voluntary Action and Berkshire Community Foundation for supporting this work. In the course of the work, we discovered that a couple of pharmacies that we visited had patients who were failing to obtain repeat prescriptions for long-term conditions, even to the extent of abandoning their medications. Difficulties in contacting their GP surgeries to arrange repeat prescription or required medication reviews were the cause of the difficulty. We contacted Berkshire West CCG about this. We would like to congratulate Reading Health Watch on their investigation of this problem of communication, which, as the paper on today's agenda shows, is illustrated by plentiful, eloquent evidence. We would like to draw the board's attention to the provision of telephone systems as a systems design problem. An inadequate system can leave the managers, controllers, unaware of the difficulties being experienced by its users. It may be asking too much of a GP or practice manager to be the designer of such a system so as to avoid indirect communication bottlenecks. Of course, we can all see them in hindsight. Will the board urgently call for an external review of the telephone systems in use at our GP surgeries to check that they present timely and representative management information in a clearly, easily accessed and digestible form so that patients' difficulties in gaining access are clear to the surgery management and their patient participation groups. Also, to check capacity against demand. Thank you.
Great, thank you very much, Mr. Lake, for your question, and also very grateful for the attention that the South Reading Patient Voice has been paying to this issue and wants about access to primary care in Reading. And I'll also add, I really enjoyed and found very helpful the event that you did around sort of more based on internet access, wasn't it, to primary care services, which was very illuminating. So in my role as chair of this board and Reading's Lead Council for Health, I am taking a keen interest in the developing picture of access in general to primary care services in the changed world that the COVID pandemic has ushered in. Work is taking place more widely around this, and I'm keen that this board, the council and partners and residents input into that work. A telephony project is underway which will evaluate the platforms being used by GP practices with the aim of identifying the best telephony solutions to be deployed across sites. Once deployed, it is envisaged that this will support collaborative working across practices and primary care networks to improve demand and capacity capabilities, as well as greater resilience within primary care. The initial evaluation stage is due to be completed in March 2022. So that I should add that last paragraph was an answer provided by our NHS CCG in their primary care commissioning role. Mr. Lake, do you have a supplementary?
Yes, thank you. I do. And this is firstly, I'd like to welcome. This sounds very welcome, this project, and I'd like to just to say that we have, while we have quite a diversity of strengths of patient participation groups across Reading, we do have some very strong autonomous groups, for example, at Millman Road and Kennet and at Belmore Park, so on. And so my supplementary question is whether these patient participation groups might be involved in the evaluation process that this telephony project.
Thank you, Mr. Lake. I can't answer that question directly, as it's clearly going to be run by the CCG and primary care. Katie Summers has indicated, which is helpful and may be able to answer your question directly. But I will just add that I think in general, as chair of this board, I'm very keen that, I mean, I think it's very important that the huge asset of the patient voice groups, plus also wider public, will be really important to feed into coming up with these solutions and to make sure that these reviews are based in real people's real experiences. So that's my perspective. But Katie Summers, would you like to come in on Mr. Lake's exact point?
Thank you, Councillor Hoskin. Thank you, Tom, for your question. And then obviously you've heard Councillor Hoskin give the actual response. The primary care team obviously work with the actual PPGs in order to actually understand about your feedback. The individual review process that's been undertaken is through our national service specification. It has already been actually undertaken with a review from individual patient groups. So I'm sure that actually the primary care team could do is actually send you through the individual service specification in order to get your initial feedback on that piece, and actually would welcome your feedback as we progress with any forms of procurements. Just to make it very, very clear, the individual practices will make a decision themselves on the individual suppliers that they may want to go forward with. The actual service specification is setting out the new roadmap about the expectations for what we expect GP telephone systems to provide. And that is very much in line with a new world that we're working towards. And it's actually in line with all the challenges that actually Tom has actually related to, but also with regards to the Health Watch report, which we're going to review later on. So I will ask literally the primary care team to work directly with Tom and the PPG groups in order to gather your feedback.
Thank you, Katie. That's really helpful. And I say, well, as you mentioned, we're going to be discussing the Health Watch report on this matter shortly. So thank you, Mr. Lake, Tom, for your question. And we'll move on. We don't have any petitions, do we, Nikki? No, I'm sure we don't.
No, we don't.
Good, good. Right, so the next item then is, well, it's the impact of COVID-19. And David, you're going to lead off and take us through.
Yeah, absolutely. Thank you, Chair. So for those that I've not met before, I'm David Munday, the public health consultant here in Reading, and Nikki is ably just getting the slides on the screen. Great, thank you, Nikki. So all I'm going to do is run through the latest position in terms of COVID, the COVID kind of case rate, etc. in Reading, and then I'll pass on the last couple of slides to Nikki Barton, who's our strategic communications manager, just to talk a bit about how we're looking to land the public health messaging with the changes coming on the 19th of July. But to start with just where we are overall with COVID, if we could have the next slide, please, Nikki. So this is just to give you an overall picture. And of course, we publish these slides as with all of our papers a week in advance. So what you've got in front of you is not the absolute latest number. And actually, it's worth just noting that in Reading, we're at 239.2 to be exact on our case rate, kind of in a rolling 7-day period for every 100,000 of population. So and our positivity rate is at 4.9. So both of those have actually dropped in the last week. So slightly different to what you've got on the slide just in front of you. And we've seen that kind of plateau probably since right at the end of June in Reading, and we're now very much in line with the southeast average and kind of below nationally what kind of case rates are. So it kind of seems that with this wave of COVID, Reading did get a bit of a surge earlier than other areas, and I think probably we had more cases that were the Delta variant when that first emerged earlier than other areas. We then got a sharper, quicker rise, but that's now, as I say, kind of plateauing off, and we're more within, if you like, what's kind of average in terms of case rates. But throughout the pandemic, of course, these things have continued to fluctuate. Some areas get more affected at certain points, others at other points. And then just on the Delta variant, worth noting that we're now, we think it's like 98, 99% of cases that are diagnosed are due to the Delta variant. So absolutely the dominant strain that we have now in Reading, like in so many parts of the country. So on to the next slide, we'll just break this down a little bit more. And I often show this slide, which is what we call our age heat map. And this is showing you that same case rate data, but broken down by age group and broken down over each day over the last month. But again, each day is representing the most recent 7 days. So that giving that rolling picture. And although the numbers may be too hard to see, it's about seeing the colour on this, and what you can see quite clearly is that the highest rates being in the 19 to 24-year-old age group by quite some margin. Again, the most recent data on this, because because what's on this slide again, we published a week ago, shows quite a drop away actually in the case rate in that 19 to 24-year-old group. So that's actually half what it was. So that's really positive. We have seen the numbers increase a bit within the 11 to 18-year-old age ranges, and I'll show you some school data in just a moment. So we are seeing case rates within that age group, and then some within 25 to 34-year-olds. And that's where the COVID transmission seems to be occurring. And the primary reason for that will be that, as I was saying at the Outbreak Engagement Board that we had a couple of weeks ago, we know that as lockdown restrictions are lifting and we're all returning increasingly to more normal ways of life, maybe not completely kind of to pre-COVID ways of life, the age group where we're seeing this transmission of the group who don't to the same extent have the vaccination protection that older populations have, either because the programme stops obviously at age 18 and isn't currently for those under 18, or because those just in the 18 to 25 group have only very recently been vaccinated and that immunity is still building, or it's still 1 dose, not 2 doses. So I think actually there's a bit of a reassurance in this picture that it shows that the vaccination, 2 doses of the vaccination, is highly effective at reducing transmission and controlling case rates. So the next slide, then, I said I would show you some school data, just shows what's happening in Reading schools, because we've all heard within the media about pressure on different services when people are isolating because they're a contact, and within schools that disruption that's occurring where bubbles are isolating because of cases. And you can see this graph just shows you over time what's been happening in schools in Reading this year, and you can see that increase has occurred in the most recent weeks where we are seeing cases in schools. This isn't I wouldn't take this data as empirical of every last case that's in school. These are just ones that have interacted with the council that we've provided support and advice to, but some of the academies wouldn't have necessarily reported into us, but just directly to the DFE or to Public Health England, but gives you a good picture of what's happening. Although I have to say that overall, when we then look at attendance data in Reading, the data shows that we compare favourably to the national average in terms of overall attendance, and to that comparison to local authorities that are most similar to Reading. So we're not getting disproportionately impacted in terms of that bubble isolation impact. Next slide, please, Nikki. So just to summarise on vaccination, just to cover off the death data first, because it's one we continue to monitor, is just to show that we're seeing very, very little COVID-related death in Reading, over these last few months, and something that clearly we continue to monitor closely, but again demonstrating the control, it seems, that vaccination is giving us in terms of the most serious impacts of COVID. So sorry, the next slide's on vaccination. I got one ahead of myself. So it was really just to summarise the picture in Reading in terms of vaccination coverage. So just to start on the line chart on the top right of the slide, the Reading coverage is shown over time and is in the dark blue, and then our comparator areas are in the orange, with the national average in the lighter shading. So the first thing that I would kind of draw out from this is to say that the Reading coverage is improving over time, clearly, but is getting closer to national average and to comparator area rates than it has been, which is really good news, and we obviously want that to continue. One of the reasons that the Reading rate does sit below the comparator areas is because of our predominantly younger population and the fact that we have more under 18s in Reading than average, and therefore we'll all, even when we have good uptake among adults, because the data here is across all residents in the borough, will of course always sit a bit below because we're not vaccinating under 18s at this point in time. And then we've also found we've been doing some proactive door knocking in Reading, where GP surgeries in certain parts of town have shared with the council where they have registered patients where there's no record of them responding to the vaccine invitation. And when we do that and we knock on doors, we see that at least half of the people that we knock on the door of have actually moved away, and the GP record hadn't reflected the fact that they were no longer in Reading. So although we do want them to be vaccinated, we kind of hope that they are being in their new place of residence. That means that actually our uptake is better than the data suggests, because clearly they are no longer in the town to get vaccinated. And then I just wanted to summarise in the bullet points then here the various places that people can still get vaccinated, whether that's for the first time or indeed getting dose 2. So we still have the mass vaccination site at the Medeski Stadium, and that will relocate to central Reading later this month. We have the pharmacies that are listed here, and access to both of those is via the national booking system, so the online booking on the NHS website. Yesterday and today we've been deploying our vaccination bus along the Oxford Road with our colleagues at ACRE to offer vaccination to the community immediately around there, and we'll be taking that vaccine bus to other points in Reading in the coming weeks. We have GP surgeries that are still completing that dose 2 offer to their eligible populations. So that dose 1 offer is complete, but clearly some of the younger cohorts still coming through the dose 2 at 8 weeks. And then increasingly having flexible walk-in options, so where people don't need to book and they're in various places around the town. So we obviously had for a few weeks the surge vaccination clinic at the civic offices and vaccinated just over 4,000 people there, and that's actually running again this weekend, tomorrow and Sunday, without the need for appointment, without a need for an NHS number. If people aren't even registered with a GP, they can still turn up, and that will run tomorrow and Sunday as part of a big push kind of vaccination weekend that's happening across the region. And there's various other sites where vaccination is occurring as part of that effort. So if we move on to the next slide, please, Nikki. So the final thing from me then was just about those step 4 restriction changes. So this, I think, summarises where we're at in terms of various government announcements. It's sometimes hard to keep track exactly in terms of what changes on the 19th of July. And it feels that over the last week or so, the narrative has shifted a bit from some things moving simply to personal choice or maybe personal responsibility to, I think the phrase that's been used by central government is about expecting and recommending certain things. So where, for example, face coverings are not required in law, still that expectation and recommendation that they're used, or indeed the rule of 6 doesn't apply. It's not a restriction in terms of indoor gathering, but we of course know that COVID is as infective on the 18th of July as it is on the 20th of July, and it's still safer to be outdoors, and there's a lower risk of transmission. So it's an important kind of time to get our messaging on correct, as we're encouraging people, we're asking people to do what the right thing is for Reading. And Nikki in a moment will come on just to talk a bit more about how we're planning to communicate and encourage people to do those things which will help control COVID here. We clearly want to learn to live with COVID and adjust back to normal life as far as we possibly can. But that isn't the same thing as saying, let's just let COVID rip then through our communities, because we know that will have significant negative impacts. So it's about living with COVID and still trying to control it, but doing so in a way where we're responsible and looking out for each other. So I will, at this point, hand over to Nikki, who can just summarise how we're planning to go about doing some of that communication to encourage people with those actions that we're after.
Thanks, David. So My name's Nikki Barton. I'm the Council Strategic Communications Manager. Apologies to people who regularly attend the Outbreak Engagement Board, because this slide will be familiar to you. And also, as David was saying, with the slides, we prepared these last week, and actually things have moved on significantly. So I'll probably talk about stuff which doesn't actually appear on the slide, because we know a little bit more than we did when we published last week. But throughout the pandemic, our strategic approach has been amplify national messages, but also respond to emerging issues locally, and also take a really local and focused approach what's needed in Reading specifically. So, you know, David talked earlier about us having a spike of cases sooner than other parts of the country. So being able to respond to those local issues and know exactly what's happening in Reading, and take the right actions at the right time is a key part of our communications approach. Next slide, Nikki. So I'm going to give you a bit more information that's on the slide, because we've sort of slightly evolved the approach since last week. But what we're effectively saying is we recognise the national position, which is that many restrictions, if not all restrictions, many restrictions are lifting or changing, and we recognise that. But as David has said, that's not the same as saying we just sit back and say, well, COVID's gone away. It hasn't. And there are clearly lots of things that people can make individual and personal choices about that will have an impact on how infection rates and transmission happen in Reading, and whether it increases, decreases, or stays the same. So we've picked 4 key public health messages which we think make the biggest impact, and that people can do themselves, that will make a difference to protect themselves, to protect the people that they love, and also to protect the activities that they enjoy doing. Because even if people want to have a debate around, you know, sort of personal responsibility or what they want to do themselves and protecting others, there's also the argument that, you know, businesses, we want businesses to stay open, we want activities to stay open, and they will also have to close if there are outbreaks amongst staff or customers. So it's about protecting yourself, protecting others, protecting the activities we love. And the 4 things that we think we'll focus on, or that we are focusing on, are firstly getting vaccinated. So having a first and second dose now, and then in autumn, if there's a booster programme, encouraging people to take part in that. And David's mentioned one element of this, for example, which is the there'll be a really big push this weekend, NHS push, to get people having jabs before the 19th. Continue to test, trace and isolate. So the message here is around test if you have symptoms, and if you test positive, or if you're asked to by NHS test and trace, you must self-isolate, and that's a legal requirement. There's possibly a bit of a sense of people doing less of that, or that having gone away, so we need to keep reinforcing that that is still in place and you're required to do that. Make the most of the fresh air, so it's safer if you meet people outdoors or if you meet people in well ventilated spaces. And finally, that and again, this had moved on since last week, the government's language had changed slightly. We were already saying that we would recommend face coverings in indoor spaces, crowded spaces, places that are poorly ventilated, or where groups of people change and mix frequently, such as pubs, cafes, public transport, indoor entertainment venues and shops, those kind of places. Clearly the national language has moved on now to expect and recommend, so what we're saying is really in line with the national picture as well. And so our local approach will be to make sure that people have the public health information, so that they understand the why behind these things, why it's important to isolate, why it's important to meet in the fresh air, but also that they've got the practical information. So where to get tested, where vaccine clinics are happening, how the booster programme is working, making sure people have got the practical information as well to take action. Encouraging people to think of others, and also encouraging people to follow the guidelines of the place that they're visiting. So many businesses, particularly smaller businesses, small or independent local businesses, might be having slightly restrictions or keeping many of the restrictions because they really want to protect their staff and customers, and we'll be encouraging people to follow whatever guidelines are in place wherever they're visiting. So that's our sort of public facing approach. I guess the final thing I would just say is about council services. So what we've done with council services is taken again a real local approach. So every service within the council is doing its own local risk assessment of the particular activity and the location where that is taking place, and the measures that will be in place, and each of those activities, whether it's a theatre or a library or reception, will be based on the local factors, the size and capacity of the building, how many people are coming in, how good the ventilation is. All of those things will be taken into account and will influence the specific local measures that are in place in that location. That's all I prepared, but happy to take questions on any of that.
Yeah, thanks. I think, oh, sorry, David. Sorry, I don't know if that was you, Deb. Right, yeah, thank you for that. I think that's a point to take questions. I have Ramona Bridgman's indicated. Ramona.
Thank you, David. And I'm chair of the Reading Families Forum, so we represent parents of disabled children and young people. There are a couple of things I wanted to say. One of them was quite a quickie, that there's a lot of confusion about whether it's the Medatski or the Broad Street Mail, and people are spending a lot of time asking each other. So if we could have a definite date and that could be communicated, I think that would be really helpful to members of the public. But the second thing is just to remind people that COVID affects vulnerable groups much more. We've heard this week that learning disabled adults are 8 times more likely to die of COVID than the general population. And we're not out of the woods yet, and vaccines aren't a panacea. They're really good. I'd recommend them. This week, we've had a parent carer of a child with Down syndrome, a young adult with Down syndrome, who's very ill with COVID, despite having 2 vaccines. We've also got one of our members, young adults, in hospital currently, critically ill with COVID-related pneumonia, despite him having 2 jabs and it being, 2 weeks after. I would be advocating on behalf of my members a really strong public health message in Reading. I think people have got more relaxed because they think, I've had 2 vaccines, it's all right. You can have 2 vaccines and still be critically ill in hospital, and that's what we've seen. And I think it's really important. I mean, I'm really sorry that Reading buses and other things aren't being as clear as London Transport is. I think it's so important. And for our families who are critically extremely vulnerable, we've had 15 months of having to be extra careful, and as the numbers explode, that has to continue, and it is such a strain. If you're trying to work out whether your young adult who's clinically extremely vulnerable can go to college, but they're not doing social bubbles anymore, it makes it really, really hard for disabled people in Reading.
Thank you, Ramona. I think that was really really helpful and appropriate contribution at this point in terms of what we're talking about. Nikki?
I'll just make a quick comment, and then David can answer the more technical bits. But just to say, Ramona, I'm really sorry to hear that. I can appreciate it's a very difficult and stressful time for those families. I should have said we are keeping our line, which is do the right thing for Reading. So what underpins our campaign is the idea that, there is a right thing for people to do, and they should be community spirited and thinking of others. Just on a personal level, I'm 9 months pregnant myself, and I feel that kind of vulnerability as well. I understand, this idea of really wanting other people to take responsibility as well, because it affects you. We've used case studies extensively throughout the campaign, and we found versus the materials that the national government put out, having case studies of local people talking about what they are personally doing or how they've been personally effective has had much more impact locally. They've been much better received and much more widely shared, and we've had anecdotal feedback from people saying they're more likely to do things differently as a result of those. And I appreciate these are very difficult and emotive issues, and it might not be appropriate, but if you did have any families who wanted to work with us to speak about any of these issues or share any of those stories, we'd be very happy to work with you on case studies which were sensitive to the situation. Appreciate that, that might not be what people want to do. Hopefully this young man
will be out of the woods, but at the moment it wouldn't be appropriate to us.
Yeah.
Thank you, though.
But if there's anybody, even if it's just, it doesn't have to be someone who's unwell, it could just be someone who's you mentioned the college example, or, you know, someone who's afraid of going back to college, because it doesn't have to be someone who's actually ill. It could be someone who's just worried about the consequences. So if you did want to get in touch and talk about any options, then please do, because we've done it across a range of things, from vaccination to community testing to reaching out to you know, specific groups within the community, and it's always gone down very well. So let us know if you do want to.
Thank you, Nikki.
Thank you. David,
yeah, so it was just really quickly. I mean, I think Ramona, all of the points you've made are really well, really articulate, and are all points well made. Just on the vaccination venue element, when people go onto the national system, they'll only be offered appointments where somewhere's live. So the message is that people can go in to book, they can see the local pharmacies, they can see the mass site. As the site moves, then obviously the booking availability will change as to where people can go. So we will make it absolutely clear in communications with the NHS as that move happens, but no one's going to get booked into the wrong site or would turn up in the wrong place, because the system won't kind of allow them, so to speak.
Right, thank you.
Thank you. I don't have anyone else indicating. Tevier has put a question on there, which hopefully someone can get back to him outside of this meeting, so I think it's important to do so, or to respond to members of the press with their questions. I don't have anyone else indicating on this. I would also, I would also like to emphasise that, obviously, and I think Nikki may have said this, it's really important that we're flexible and can respond quickly to the situation. So we don't know what the reaction of people and how people are going to act from July 19th onwards. And I think how our communications are framed may respond to that. I mean, I personally, this marks me out as an amateur when it comes to the world of public communications. Want to take quite a militant line and trying to encourage people to wear masks on buses and crowded spaces. I am encouraged to believe that a softer line of encouragement and community and looking out for each other is maybe more effective, and I go with that. And it's a shame that we're in a situation whereby masks aren't going to be legally required in certain situations, but we are where we are. So I suppose my point is we will have to respond very quickly to the situation as it develops over the coming months. Sorry, Councillor John Ennis. John, you're indicating.
Yeah, thank you. And just to introduce myself, I'm John Ennis. I'm the lead counsellor for adult social care. So it's my first meeting. Thank you. I was just going to ask a question, because I think the mask situation could develop into one of conflict. I've already seen this in Reading itself, where there are I use the word small number, but I would say small but significant number of using the word quite militant anti-mask wearers who believe it's over. And I've had comments. And I've seen them in shops and in pubs. I don't know if that's been taken into consideration, the situation where there is potential. I think there will be potential conflicts, and individuals who are wearing masks will be identified. Either those who are not wearing masks also could be identified and conflict arise. I don't know, any comments or any thoughts about that?
Thank you, John. I think that's an important point in terms of the potentially divisive nature of asking for people to take a personal, make personal judgments about something that's about collective community safety. But David, you about to?
Yeah, I mean, I think Councillor Ennis, that's a really good point to make, and I'm not sure we've got the perfect answer to that. Certainly, we continue to link very closely with some of those settings where, as we're kind of saying, it's not the law, but it's recommended that face coverings should be used. So, be that shops, a pub or a cafe, to take some examples. So our high risk settings team have linked in with those kind of venues throughout the pandemic, and as things have moved, whether it's about who can be open, who can be closed, whether it's about QR codes to check in, when that was instigated, whether it was then about face coverings when that needed, when that was legally required, etc. We've linked closely with them, and we'll continue to do so. And I hope in doing so we'll pick up where that potential conflict arises, so that we're kind of sighted on that and can be supportive. I think overall, my feeling in Reading is that people have followed where there's guidance. So, for example, the 2 metre rule was never law that you had to be more than 2 metres away from people, but generally it became increasingly accepted and usual for people to adhere to social distancing, although clearly not universal. My hope is that as we move into a bit of this living with COVID, that use of face coverings as an optional but expected thing helps diffuse some of what right now feels like a bit of a unhelpful, polarized kind of debate. And my hope and expectation, maybe naively, is that we move into that slightly more settled approach where not everyone is going to take the choice to use a face covering, but hopefully more will, and some of that tension with it diffuses. So certainly it's one to keep an eye on and see how that changes over time.
Thank you, David. And as I say, it'd be really important. So we'll be very alive to the situations that develops in the coming weeks. Thank you, John. Thank you. Right. So let's. We do have a lot on the agenda, so we do need to move on. So we've got the impact of COVID-19 on primary care, and I believe we have Helen.
Chair, I think we're giving our secondary care colleagues the first bite of the cherry as they've got to go.
Yeah, no, that's all right. Thank you, Andy. So in terms of we need to move the slides on, don't we, to the secondary care? Is that great? That's that Dom.
It is. Hello, Councillor Hoskin. Hello, it's Dom Hardy here. I'm the Chief Operating Officer at the Royal Berks FT. I've just got a couple of slides actually, so I can be hopefully relatively brief for everyone. We could just go on to the next slide, please, Nikki. The first of the two slides I've got is just to give some insight into the modelling that we've got access to around expectations for admissions from COVID. I caveat this by saying the modelling is only as good as the data that's inputted to it and our ability to look at the variables around this. However, that said, we are still tracking below the central assumption in the green line that extends to the right. And that means in practice, we're having only a handful of admissions each day, 2, 3 perhaps maximum. And so in total today, we've got 10 COVID positive patients in the hospital, 9 of whom are on one respiratory ward and 1 of whom is in ICU. So the data that David originally presented around prevalence and the age groups in which prevalence is highest is reflected both in our data and the efficacy we think of the vaccine, but also in the kind of patients who are coming to us. They're mainly younger, and they've either had 1 or no doses of the vaccine. That does mean, for the majority, that they stay with us for a shorter time. So there are some upsides to that. But I hope that just gives the board here and colleagues on the call a sense of how this is, for us, slightly different this time. If we just flick onto the second slide, I'm going to just broaden out the topic for a minute. The other difference this time is that we are ferociously busy with 2 other massive cohorts of patients. So first of all, the number of patients who are attending our main emergency department is running at the moment at about 22% higher than this time 2 years ago. That means we're crudely seeing around 400 patients a day compared with probably about 320 or 330 on what was ordinarily a busy July day. That's a really extraordinary number, and it's in the context of all of the urgent care services across our patch being very, very busy. This isn't just about the Royal Berkshire Hospital, this is about everywhere. And that is filtering through into admissions and making us busy from an acute medical perspective generally. We're also, of course, working really hard, as this slide shows on the penultimate bullet point, to make sure all of our elective work, all of our routine surgery is going ahead as quickly as possible to get through the backlog of patients that we've inevitably accumulated over the last 15 months or so. We're continuing with all of that work. We're starting to see some really good headway made. I'll give you two examples. Firstly, we had around 500 children waiting for ENT procedures, ear, nose and throat. That's down to about 25 now, which is a massive improvement in the position and down to inevitably a massive amount of hard work by our team. And for those waiting endoscopy procedures, a key diagnostic procedure, particularly for cancers, we've now got only a handful of patients waiting beyond the 13-week mark, and anyone who's urgent is being treated within the time standard that we expect. And that's a really fantastic performance and means hopefully that people can get the diagnosis they need and in many cases be put out of the uncertainty that they otherwise face. So that is going well. A reflection on two future points of view, one from Monday and then looking slightly further ahead towards winter. We will be keeping all of the usual infection control on visiting measures in place. So we're continuing to impress the importance of mask wearing, for example, and our current limited visiting procedures will continue to apply. That's because we recognise that hospitals are the kind of place where COVID can spread quite readily in an indoor environment with a large number of people circulating. And so we, like other hospitals, will be maintaining those measures. We're also, as this slide says, finally preparing for winter, both internally and with our colleagues around the system. We believe that we may not just face busyness because of COVID, but also because of RSV, so bronchial conditions in children, where I think we're beginning to see the early stages of a real increase in cases, potentially flu, but also continuing to sustain our routine surgery as well as our other urgent care on the medical and surgery side all the way through the winter. We're envisaging a very, very busy time. And so what we're particularly keen to do is avoid those who don't need to come to hospital coming to us in the first instance, particularly to ED. And that will be an ongoing process that we follow up over the coming weeks and months. So I hope, Councillor Hoskin, that gives a picture not just of the COVID position, but the slightly wider context that we're operating in at the moment. Obviously, I'm very happy to take any questions that people may have.
Great, thank you. I think that was that's very helpful and reassuring in a number of ways. Any questions? Anyone's indicated. Any questions? Any points anyone would like to raise? We haven't, in which case it doesn't look like it, in which case, thank you very much. Andy, were you?
No, I'm coming in for my next bit.
Okay, no, so that's, thank you very much for that. And yeah, well, as I keep up the good work, thanks very much.
Thank you, Councillor.
Right, Andy Czerski, you're going to...
Yeah, thank you. Thank you, Dom, for your presentation. And I'll come into to the item on the primary care. So I'm Andy Czerski, I'm a GP at the Emma Green Surgery and the Vice Chair of the Health and Wellbeing Board. So the first slide, just to reflect also on what Dom said about the increase in workload. There's been a dramatic increase in primary care as well as across the whole system. And the numbers there show some of the activity that was going on in April 19, so pre-COVID, the obvious reduction in April 20 when we were just going into lockdown from 2020, and then the numbers for April 21. Just thinking back to last year, although April was a quieter month because everybody went into lockdown, obviously. By the end of May, going into June, certainly by July, we were pretty much at approaching pre-pandemic sort of primary care activity levels. So primary care very quickly had to adapt to new ways of working, but also the activity and the went back to what we were doing before. I think things to look at there is probably the difference in the number of telephone appointments, which is obviously how we've been told to operate since March 2020. and then the number of face-to-face. So you can see there's obviously quite a big difference from April 20, when everything went very much to telephone and almost hardly any face-to-face. But throughout the pandemic, face-to-face appointments have continued. Nurses have still been seeing patients for routine work, for blood tests, for cervical smears and child immunisations, and doctors have been seeing patients for face-to-face appointments as clinically needed. We try and deal with as many things as possible on the phone, but if a patient absolutely needs to be seen, absolutely they do get seen. And also the number of face-to-face appointments is gradually increasing over time. I think you can see there on the April figures, it's about 47%, 46%, and I'm sure it's, if you look at the current data, you'll find that it's more and more. And I can reflect from my own practice here, we're opening up more rooms to be seeing patients rather than just the one clinical room, and so the face-to-face workload is definitely going up. The thing to also notice is that home visits are a bit less, but not dramatically less from pre-pandemic times. And the online thing is different. The numbers aren't huge there, 46 to 310, but I don't think we're capturing the online work. It's a new way of working, and I don't think we've quite worked out how to code and find, you know, for then searching for the activity. We haven't quite worked that out as well. We're just sort of doing it, but we're not counting it. So the online work, which is both in emails, online requests through our websites, we're doing a lot of work through text messaging. We haven't quite captured that. Can we move on to the next slide, please? And I think this data just shows the overall activity. You can see from beginning of this on the left-hand side, what it was pre-pandemic back in April 19. You can see the dip in April 20, and then the gradual increase over time. And you can sort of get a gist from the blue line, which is the face-to-face line, that it's gradually increasing from sort of November onwards, and certainly I think if we had data for the current last few months, you'll see that's going up even more. So that just sort of gives a sort of flavour of how things are working. Can we move on, please? So as I mentioned, you know, we have to be clever about how, you know, learn how to document the work we're doing. Face-to-face appointments are taking longer. We're still having to use COVID infection control measures. I think, as Dom mentioned, at the hospital, in primary care, we're certainly still wearing masks, and we're still going to be asking, and no doubt going forward, that patients wear a mask in the surgery. We're still, as it says, donning and doffing PPE, so we're having to put the gloves and aprons on, and we're having to clean the rooms down, and we've got to have enough space for patients to sit comfortably, socially distanced in the surgeries. So all these things are challenges in certainly some practices who have got more constrained facilities. I've mentioned about the data. I've mentioned about the return to face appointments, and we certainly won't go straight back to doing everything face to face. I think there's been going forward, there'll be a mixed model. We'll keep the benefit of telephone appointments and online appointments. A lot of patients have actually appreciated it doing it that way. Housebound patients have not wanted to have people coming into the house, so they've been happy to have things done over the phone. If they needed a visit, they would still get it. Patients working prefer to deal with a problem on the phone than having to take time off work. I know that the report coming up later will paint a slightly different picture, but I think, you know, there's a blend of options now. I think where maybe in April 19, going pre-pandemic, we were talking about providing more online convenient communications with the surgery. The pandemic has actually almost forced that upon us, and we've had to learn how to manage that. And so those things won't go away. If anything, they'll probably increase in time, and there will be a blended offer of both telephone, face-to-face, and other digital options of contacting your surgery for your clinical needs. Next slide, please. So from a recovery point of view, we during the pandemic, there were 2 phases where we had a respiratory hub in place to help with seeing the most unwell patients and those suspected of having COVID. And that hub closed in March when the second wave over the new year eventually fizzled out. Practices were then having to see their own patients, and luckily the numbers have been very small. And certainly with the current wave of younger people being predominantly getting COVID, there've not been many of those that required actual care here at in the GP surgery. I've mentioned about new models of access already. Digital inclusion obviously is going to be part of that as we move forward. So some people are digitally capable, as most of you are on this call because you're on a Teams call, whilst other people are not. And so we need to make sure we reach out to those to offer them all the digital options, those that they may be able to cope with if they can't cope with something like a Teams or a Zoom call. And we're throughout the this year, and well, from the tail end of 2020, most practices have been involved in the vaccination program, COVID vaccination program in some way, working in their primary care networks as teams. For example, here in Caversham, the 2 practices work together to provide a service here at the Emma Green surgery, and there have been lots of collaborative arrangements like that across the whole of Reading. The numbers there say 115,000 vaccinations, and that's to date provided in GP surgeries. There's 3 sites still going with the phase 2 part of the program, which is the 18 to 50-year-olds. And we're now getting this last night there was a first webinar from NHS England to give us guidance on the initial plans for the autumn booster phase, which will be phase 3, and linking it to the flu immunisation campaign. There's still quite a lot of questions and that are unanswered. I think there'll be quite a lot of logistical issues to overcome. But in my discussion with my partners, we feel it's the right thing to do. I think GPs and their practices are well placed to vaccinate our most vulnerable, as we do every year with the flu vaccine, and linking it to the COVID vaccine, despite the potential logistical issues, is the right thing to do. So I'm sure the primary care networks and all the practices that work within those will be signing up to do that phase 3 booster campaign. Next slide, please. And yes, we've been addressing backlog of work, chronic disease. Like I say, we were doing immunisations all the way through COVID, and cervical smears. And I'm sure there were places where they struggled to do that, and the numbers are not probably as high as we'd like them to be, but they're not bad. There are various funding arrangements to support the whole COVID response. We had to put in oximetry at home for patients who potentially had COVID to support them at home. We've got long COVID patients who are struggling to recover from their COVID illness and are needing extra support, and then referral on to specialist services. And we're catching up with a lot of the chronic disease management, sort of diabetes, heart disease, blood pressure, and a big push was made to catch up with learning disability health checks. Obviously, they were vulnerable and they didn't want to come to us. And they didn't want us going to them, and so now we've managed to do quite well. But this year certainly we're really making a real push to make sure all those learning disability patients get their regular health checks, whether it's remotely or face to face, to get them up to date. Immunisations I've mentioned, and yes, I think the inequalities issue, it's not just learning disabilities, but all our patients that have in some way struggled through COVID. Certainly we've got plenty of patients with severe mental illness who also need physical health checks as well, and we'll be trying to address any inequalities that may have occurred through the pandemic. I think that might be the last slide. Okay, just a few things there about the on-the-day demand. I think there was a workshop at the end of May. Some of these are to help support our colleagues in the emergency department. I've mentioned there about understanding the workload in primary care. We're taking calls from 111. Previously, they were all sort of clinically validated and passed on to us. Now we're looking at letting the call handlers pass calls to us as well, similar to how the out of hours works. Even though we have our own phone systems open during the day, some patients choose to ring 111 and then they can still be passed to us if needed. We're looking at the telephone access issue, and I think there's an item on that for later on in the agenda. They've been looking at standardizing messages across GP practice, just looking what's the best messages to inform patients about how to access services and what the practice can provide. Looking at managing the increased telephone workload that's out there and how to manage that workflow, we call it workflow, into passing it on to the relevant staff, and not just the GPs, but other clinical staff that work in the surgery. We're looking at overflow arrangements where practices are finding they're just absolutely flat out, and towards the end of the day, for example, we heard that there's lots of children with illness. You know, what can we do maybe in a collaborative way to make sure patients still have somewhere to go, even if their own practice is absolutely full and flat out and there's no appointments left. So that's being looked at as a solution. And also using the community pharmacy consultation service, the 111, if you ring them and you need just a pharmacy to help you out, they may direct you to that service. There've been there's the option also for GP practices to do that. So if you have a problem that the pharmacy can deal with, they might suggest you go to the pharmacist directly, or it can be done through a referral through this initiative. Okay, I think that is the last slide. I think, yes. So any questions on that are most welcome.
Great, thank you, Andy, for that. And yeah, if anyone has any questions or points, indicate now. Other than, I mean, thank you for the update. I think that's really useful to get an understanding of the pressures. And I think, well, also quite extraordinary in a sense that you can see how the level of activity sort of returned to the norm of where we're at. And we know that primary care was under incredible pressure anyway before the pandemic. And you managed to get through 115,000 vaccinations on top of that. So extraordinary work. I suppose my only point from that is the sustainability of that level of pressure when it looks like vaccinations, as we talked about the booster flu vaccinations, it's like going to be an ongoing a major part of the primary care's role into the future, and the sustainability. It's not really a question to answer, but obviously I can see that as a danger in terms of the sheer workload. Unless you wanted to.
Yeah, I was just going to say, obviously through the whole pandemic, I think the thing that kept us together in our practices, in our teams, is to sense check everybody's well-being. I think everybody stepped up in difficult times. I think when the vaccination came along, I think everybody felt a duty. It was that this is what we had to do, and yes, we did that on top of everything else. But you know, yes, it was a huge achievement, and we're proud of it. It was hard work, but I think that hard work and sense of achievement kept us going. I think there is an element of fatigue in people. I certainly personally have felt I needed time off, and I think, you know, we've had to tell people to take annual leave because they were so worried about not taking it, and leaving their colleagues in the lurch. But I think we're supporting each other. I think everywhere across the system we're realizing that well-being is important, both within your staff teams. And I think everybody's been making that you know, very high on the agenda. If we can stay well and positive and get enough rest, then we can face these challenges, and we can step up to the phase 3, the booster campaign, and the challenges that will bring. So I think our staff just need that bit of rest over the summer and get geared up for the winter. Thank you.
Okay, thank you, Andy. I haven't seen anybody indicate, and so in which case, thank you very much for that presentation. And we can move on to the next item, which is the Dementia Care and Support report from the Alzheimer's Society. We've got friends from the Alzheimer's Society here to present. I suppose, which way there is a covering report from the council, Karen Buckley. I don't know whether it's worth doing that. Do you think after the presentation it make more sense, or before, Karen? I guess.
Happy to do it either way, and I'll keep it short. So thank you, Chair, because of time. So for those who haven't met me, I'm Karen Buckley, Acting Consultant in Public Health. My colleagues from the Alzheimer's Society are going to lead on this, but just to give some context, dementia has been a priority on the previous health and wellbeing strategy, and so key is to ensure that it remains a priority group on the new strategy, and so that's what we want to achieve from today. So colleagues from the Alzheimer's Society will talk through the evidence, and so for us I think it's just about making sure if we take it forward under priority 2, which is around supporting individuals at high risk of bad health outcomes. So you can summarise again at the end, but I'll hand it over to Laura.
Great, thank you. Laura.
Thank you, Karen. And I'll try to share my screen so that you can see my presentation. Give me a second. Let me know if you can see it.
Not. Oh.
Hopefully.
Something's happening. It's a blank screen at the moment, but that's.
We can now.
Yeah, here we go.
It's great. Thank you. So yeah, good afternoon, everyone. I'm Laura, and I'm the Public Affairs and Campaigns Officer for Alzheimer's Society. And today I'm here with Keelan Erblasser, who is one of the co-authors of the report I will be talking about today. But I'm also here with Joanna Rice, who is our Dementia Connect local service manager here at Alzheimer's Society. And yeah, so the report, as you can see from the slide, is called From Diagnosis to the End of Life, the lived experiences of dementia care and support. So our report mainly analyzes the gaps between what care and support, the current guidance and the legislations affords to people with dementia, and what care and support people are actually receiving from diagnosis to the end of life on the ground. And this report mainly includes recommendations that are addressed to local decision makers that can be implemented to address the care and support needs of people with dementia and their carers. So this report was actually researched and written before the pandemic, but I will also refer to the pandemic and the impact that COVID has had on people with dementia and their carers throughout my presentation. Before though I start presenting, I would like to say that I'm delighted to see that the Council has committed alongside West Berkshire and Wokingham to prioritise people with dementia and their carers in the joint health and wellbeing strategy. And then you're committed to introduce an integrated programme partnership with other sectors for the early diagnosis, rehabilitation and support for people affected by dementia. So I really hope that my presentation today and the recommended reports will be useful to inform your dementia plans. So in terms of how we structure the reports, we use the 4 stages of the NHS England Well pathway. So diagnosing well, supporting well, living well and dying well. And in terms of how we gather our evidence, we use national guidance and legislation as a benchmark. We conducted this literature review of existing pathways, standards and data sets. We interviewed and surveyed professionals across the pathway, and also we spoke with people affected by dementia through focus groups and interviews with them. A recurring theme across all the stages of the pathway was a sense of disjointing and fragmented care. So here I gathered some quotes which kind of show the impact of these disjointed care. I won't read them all, but so we really think that you know, there are some examples of good practice happening across the country, so we included those in the report, but we still think there is much work to be done. And so this is why we have compiled a series of recommendations that you can all look at to improve dementia care in your area. So starting from the first stage of the pathway, which is diagnosing well, one of the main issues that we found is that people are being misdiagnosed, particularly younger people, or the opportunities to identify dementia early are being missed. We also found that referral processes can be confusing, with people feeling a bit daunted about what comes next. And then what we also seen is that the variation between memory services and limited performance data can actually make the initiation of service improvement projects quite challenging for services and commissioners. And also, lastly, we've seen that the delivery of the diagnosis itself, including information about the subtype and tailored information to the patient, is quite variable and too often focuses on what people can no longer do rather than what they can do. And so it's really important to recognize that the diagnosis of dementia doesn't mean a death sentence. So people can do and do live well with the condition. So really, it's important that professionals frame the diagnosis as positively as possible. So to address the issues I just described, we really think that each CCG should have a dedicated dementia lead. We should be responsible for ensuring the delivery of training to GPs on referral criteria, diagnosis, and personalized care and support planning. But we also think that to facilitate the diagnosis of dementia, specifically the complex cases of dementia, there should be formalized arrangements that enable multidisciplinary team meetings between memory service clinicians, neurology, and neuroradiology. And also, we know that people access a diagnosis at different stages of the disease journey, and so therefore have different needs. So we really want to make sure that they have access to allied health professionals, because that ensures they access the right services at the right time. So we really want to make sure that memory services have clear referral pathways to enable access to allied health professional during the diagnostic process. But I think a key recommendation at this stage of the pathway is the integration of dementia advisor services within memory services. So people really told us how important dementia advisors were to their care and support needs. So we really think the memory services should all include dementia advisor services, with people automatically referred to the service unless they opt out. And lastly, we really think that it's important that people have access to follow-up opportunity to discuss their diagnosis. So we've seen some memory services, because they are commissioned as diagnostic services only, that kind of create a systematic pressure to discharge patients once a diagnosis has been given. So that kind of limits the extent to which people can access follow-up opportunities to discuss their diagnosis. So we really want to make sure that people can discuss the diagnosis even later on. Of course, what I presented just now are the challenges that people were facing at the point of diagnosis before COVID. But of course, we cannot ignore the impacts that COVID has on especially diagnosis rates. And so from February 2020 until February this year, we've seen a steady decline in dementia diagnosis rates, which of course across the country have fallen well below the national targets. We actually believe that there are now an extra 33,000 people living without diagnosis as a result of the pandemic. So that means that many more people are actually living without diagnosis of dementia, and consequently, they are living without access to the support that they need. So rates actually fallen for many different reasons, but one of the main reasons is because the way people interacting with their GPs have changed. So that has led referrals from primary care to memory services declining. But also another issue that we've seen is that memory services have reported to a significant backlog of appointments, leading to increased waiting times. So we really want to make sure that people can access their GP face-to-face to discuss concerns about the symptoms, but also we want to make sure that memory services have sufficient workforce and resources in place to cope with the current demand. So moving on to the next stage of the pathway, which is supporting well. And by supporting well, we'd actually mean care and support, which is provided within 1 year of the diagnosis. So the main issue that we found is that information which is provided at the point of diagnosis is not actually being delivered in the right way. So some people told us that they received too much information, and so they felt overwhelmed. But some others actually did not receive enough information about their diagnosis, and this is equally problematic. We also found that people are struggling to access a care coordinator, and you all know that under NICE guidelines, a care coordinator is the person who can help the patient to coordinate their care from the point in which they're diagnosed up to the end of life care. And so a care coordinator actually helps people navigate the complexity of the health and social care system to make sure that people can get the right care and support. However, we found there is a lack of clarity around the role of the care coordinator. Some professionals told us that they didn't even know they were someone's care coordinator, so this is quite problematic. Another issue is that care planning, including advanced care planning, sometimes can be insufficient, and the specific needs of people with dementia are not taken into account. Many people with dementia told us that they didn't know that they had the care plan, or they couldn't access their care plan. And this is very important, given that the care plan offers people with dementia something tangible to use when taking control of their own care. And equally about advanced care planning, I think the main issue that we found is that some professionals felt uncomfortable about initiating advanced care planning conversation. And also we heard discussion around end-of-life care provisions only occurred after a crisis. So that meant the care workers and hospital staff were often the professionals who had to engage in this conversation, and probably they were not always the best appropriate people. And I think the key issue is, as well, that we found is that the provision of post-diagnostic support interventions can be quite variable and inappropriate. So we had the people aren't being offered intervention as standard, or they struggle to access them. But also we've seen that sometimes intervention can be inappropriate, particularly for those we usually call hard to reach groups, such as BAME communities and people from LGBTQ+ community. So in order to address the issues I just described, we think that all people with dementia should have a named care coordinator. And this will actually ensure that people with dementia know how to contact them for consistent and proactive follow-up care and support. We think, again, that post-diagnostic support interventions which are provided should be appropriate and tailored to all patients, and considering age, ethnicity, religion, gender, and sexual orientation. But also key recommendations for us is not just to integrate dementia advisor services within memory services, but also within primary care. So we've heard actually that integrating dementia advisor services within primary care, so mainly GP surgeries, upskilled primary care colleagues in dementia care and offer GPs a service to directly refer into. And lastly, about advanced care planning, as I said, because we heard mixed views about when advanced care planning conversation should happen, we think there should be clear responsibility at local level about who is actually responsible to initiate this conversation. So moving on to the living well stage of the pathway, and we took living well actually to mean a year after a diagnosis. So we actually seen that our research found that people receive limited access to coordinated, proactive and ongoing care and support. But also we found the follow-up care is not the same for everyone. So many people are actually left to manage the condition themselves. And I think the main issue here is around care plan reviews. So we found that many reviews aren't actually happening consistently or as regularly as required. But also another big issue that we found at this stage of the pathway is around hospitals and care homes. So as you might know already, hospitals are best avoided for people with dementia, but sometimes they are necessary. So, however, we did find variable practice in hospital care for people affected by dementia. And equally for care homes, we heard many struggled to provide a level of care appropriate for people with complex needs. A key issue as well at this stage of the pathway is carers of people with dementia. As you all know, many people receive most of their support for their primary informal carers, but carers as well are struggling to access support services for their own well-being. So we found a series of issues around carers assessment, but also a series of issues around respite care, in particular respite places not being dementia appropriate, and that means that carers have not taken, decided not to take breaks away from caring because respite places were not dementia appropriate. And so in terms of what can be done to address these issues, we think that because a lot of people spend a lot of time in care home usually, and we've seen that there is a lack of clinical inputs within care homes, and that kind of leads to a sort of revolving door between care homes and hospitals, we think that local multidisciplinary teams should be formed to assist the local care homes. But also because dementia is a complex condition and people with and care is usually provided by different professionals, we really want to make sure that all the professionals who are involved in a person's care should be trained to at least the Tier 2 of the NHS SPEC dementia training standard framework. And in terms of supporting carers of people with dementia, we think there should be more support for them, including proactively offering carers assessment to all carers rather than waiting for them to request an assessment, making sure they are provided with straightforward methods of booking day and overnight care in advance. But also it's important that as a local authority, you provide an accessible list of recommended an accessible list of recommended local respite care services, and make sure that these respite places are dementia appropriate so that actually carers can take breaks away from caring. And of course, again, as I said, these are the challenges that carers and people with dementia were facing before the pandemic. However, the pandemic has had a devastating impact on their lives. We've seen many people with dementia suffering significant deteriorations of their mental health. Many have suffered a significant cognitive decline, and the impact has been particularly devastating for those living in care homes. You all know that because of the restrictions, social contacts, they've not been able to interact with their carers, but that has meant that many people with dementia have lost their ability to formulate sentences, remembering words, and even feed themselves. Compounded to this, we've seen a decrease in the numbers of people receiving care plans or care plan reviews over the last year. So what we would really like to happen is that the Council bring forward care plan reviews as a priority, and in these care plan reviews proactively identify people who need cognitive rehabilitation and make sure there are professional and services in place to meet this need for rehabilitation. But equally, as I said, when we talk about people affected by dementia, we just don't talk about people who live with dementia, but their carers. Carers, if you might all know this, have been experiencing an increasing sense of isolation, have been unable to access respite care because the support groups they used to rely on have been suspended, day centers have been closed. So at the same time, the dementia symptoms of the loved ones have worsened. And so all of this has meant that led to a negative impact on their physical and their mental health. So what we really want to make sure is that the Council proactively offers a new carers assessment to carers to address whether their support needs might have changed, but also what we really want to make sure is that respite services are reopened at the earliest opportunity, because in this way we can make sure that carers take breaks away from caring. And so moving on to really the two last slides. So dying well, the end of life care. The main issues at this stage of the pathway are the following. So people often struggle to access palliative care, including end of life care. And there are many different reasons why this happens. One of the problems is around lack of staff skills, lack of coordinated care, but also a general lack of awareness that dementia is a terminal condition. And then a key issue as well is that advanced decisions are sometimes ignored, meaning that the interests of people and their wishes at the end of life are not being fulfilled. So the last slide is really about how to address these issues around end-of-life care. And so as I mentioned before, hospital admissions are common for people with dementia, and especially more common in the last years of their life. So resources should be really targeted towards reducing these hospital admissions. And we think this can include integrating services between health and care, upskilling care home staff, and increasing access to out-of-hours specialist support. And one way of achieving these may be local multidisciplinary teams assisting care homes. And lastly, we also think the local services should be set up to ensure that professionals involved in end-of-life care can easily and quickly access advanced care plans. So really, thank you very much for listening to our presentation. As I think I showed you that, yeah, from diagnosis to the end of life, people with dementia face a series of challenges when accessing care and support. And that, you know, we do think that the government and national bodies need to make further progress on dementia care quality and outcomes. But of course, we do think that local decision makers and professionals are really responsible for developing dementia pathways and strengthening them. So as I mentioned at the beginning of presentation, I will be more than happy to support the Council with developing this integrated program of support for people affected by dementia. And yeah, so if you've got any questions, Keelan and I and Joanna are happy to answer any questions you might have. Thank you very much.
Thank you very much for that presentation. And as Karen said at the beginning, this is particularly helpful moment as we are looking to develop our plans, our action plans, in order to around this area in particular. Karen, did you want to say anything else on that matter?
I don't think so. I think I probably covered it in the introduction. So I think obviously, yeah, the intention, as we said, is to take it forward as part of the health and wellbeing, the new strategy, and that priority area to, you know, the impact that COVID's had, and that needs to be a key priority, because unfortunately it has had an impact on that group, both directly and indirectly, because of services and what we've been able to offer. So we're aware that, you know, we've got a lot of work to do to take that forward. So a helpful report and helpful offer of support as well. So thank you.
Yeah, I thought that helpful offer of support I particularly picked up on, which is great. David, you're indicating, David Monday.
Yeah, thank you, Chair, and thank you for a really interesting report. I just had two really quick questions, which I think would help with the landing of it locally for us in the health and wellbeing strategy planning that Karen's referred to. And I think one is that we know with, you know, obviously with a lot of different diseases, their impact is not felt equally across populations, but it clusters within certain groups, and we see inequalities in health outcome. And I just wondered, from your kind of expertise, the degree to which we see that as a feature of dementia, and whether it's by gender, whether it's by ethnicity, whether it's by socioeconomic status, whether what you're seeing, you know, from those impacts, whether it's on the diagnosis side or whether it's the kind of living with side, whether that's a particular feature. And because if it is, that's something that we need to be we kind of need to understand that then for us locally and attune our strategy accordingly. And then I guess the other bit, and I appreciate it's probably outside of the scope of the report, because I know this report wasn't about the prevention of dementia, but it isn't an inevitable outcome of aging either. And I just wondered if you had any comments on kind of any latest thinking on how that dementia prevention bit can be moved forward. Is it simply a healthy lifestyle message, you know, what's good for the heart's good for the brain, and it reduces, or is there anything more than that? So just interested in your comments on those 2 points, please.
Yeah, so answering the first questions about socioeconomic deprivation and ethnicity, definitely that has an impact on diagnosis rate, has an impact on other aspects. So clearly the inequality that you're talking about reflects as well on the dementia population, as we call it. So definitely there's an impact. And we've seen that not only in Reading, but, you know, in other areas of the country. So this is something that is true, unfortunately. So definitely, for example, people belonging to BAME communities usually have lower diagnosis rates. I mean, my colleague Keelan probably would be the best person to answer these, but I mean, these are the general findings. Around like prevention, yeah, so we purposely decided to actually not mention prevention in our reports, because again, there wasn't like enough evidence for us to actually put that in the report. I think I can tell you that as part of the focus groups groups that I've been attending with people affected by dementia, I think one of the main issues that we've seen is that people sometimes with these kind of healthy living messages, they are a bit concerned because they think that, oh, I've done everything to prevent dementia, why I've still got dementia, right? And I think as public health, you're interested in how you can also frame, I suppose, the issue to people living with dementia or people who might develop dementia. So I don't know if, you know, my colleague Keelan want to come on this, but I think that's probably only what I can say.
Yep, thanks, Laura. And I'm Keelan. I'm one of the co-authors of the report. So for your first point, yes, ethnicity is a really big factor. And there's you can kind of split the issue in two ways. In the first, that in some communities, dementia, there's not even a word for it. So that presents itself as significant challenges. So in South Asian communities, there's not a word for dementia, and the words that they do use are quite stigmatized and kind of entrenched in taboo, and that kind of affects people reaching out to their GP or in terms of their understanding of the condition. And as Laura said, you do see lower diagnosis rates for different communities. And prevention is a really good point. So what we've been calling for with kind of different local areas is ensuring that kind of health checks are taken up. And I think there is some data that says you're more likely to get a diagnosis. The people that go for a health check are more likely to have a diagnosis of dementia because it's picked up quickly. But I think the take-up rates of health checks nationally is really poor. And I think deprivation as well, in terms of risk factors, you know, in high levels of deprivation, you're going to see those lifestyle behaviours or choices, and you're going to see those higher rates of risk factors for dementia. So things like diabetes, hypertension, also alcohol abuse as well. And that also contributes to kind of those vascular dementias, which I think is around about 20% of all dementias. I hope that kind of answers your question, David, slightly.
Yeah, really helpful. Thank you. Yeah, and I think, as I say, I think the task for us then with our local strategy is how we take that on board and ensure that that is seen within our planning on this. Thank you.
Thank you. Katie Summers.
Hi, I'm Katie Summers. I'm from the CCG, where I'm Director of Partnerships. Andy Chesky might want to join me in this response. I really welcome this report. It's really enlightening as such going forward. I think from the healthcare side, we've been very distracted with a thing called COVID and vaccinations, and actually we're coming now out into recovery phase, but actually it's putting a light on where we've really got to focus on improving their lifestyles and health issues that people actually have. We have done previously a huge amount of work, and I'm sure, Laura, you're already aware of this, in Berkshire West in supporting dementia, but I think now is a time where we do a bit of a restock, really think about the healthcare delivery going forward to make sure that we're also picking up those people, which Kelvin has just literally talked about, those health checks types of approaches, so we can identify people earlier on. We've got to be supporting those people to get the early diagnoses. Obviously, most of the healthcare services have been quite swamped with tackling the COVID. So I think it's about rebasing things as it is at the moment. And actually, with Alzheimer's and with any of the healthcare services, it is going to have to be slightly differently with the approaches that we take forward to protect individuals as well. So I'd welcome literally conversations with yourselves, tying it in with other people within the CCG about how we could support healthcare delivery in a very different mechanism going forward. I do know at the moment the Reading Integration Board have also wanting to really focus on health checks. So actually there might be something that we bring in to the Integration Board as a focus to really say, look, we're not just focusing on cardiovascular disease, but what we're trying to do here is also tackle information that will support dementia going forward. So I'd welcome this and actually work with you in a more joined up way going forward. So thank you very much.
Yeah, and on this point, Katie, what I would like to say as well is that I've been I'm a core member of a series of CCGs and, well, dementia strategy steering groups across the south of England, including Buckinghamshire and others. So I can also provide a sort of, additional insight from other areas as well, which usually other CCGs and council have kind of benefited from as well. And also, I think for us, what is also key is the element of co-production, which I know is something that the CCG is also very interested in. And so I'm also happy to kind of, provide, liaise with some people with dementia carers to kind of share their own experiences of accessing carer support in the area, if that was something that interested you.
It would be really interesting. I must admit, whilst you were speaking, I was just quickly looking up the analytics for the board, if this is okay, Councillor Hoskin, to actually give a perspective. So I could only get the information for just Berkshire West, but the prevalence rate of dementia across Berkshire West is 0.67%. That compares nationally to an uptake of 0.79% and regionally 0.84%. So this is what I'm saying here. I think what we've got to do is really tackle this head on, really going forward. So I'd welcome this focus as well. Thank you.
Okay, thank you. Thanks for that. And that's I've got Councillor John Ennis indicating. John.
Yeah, thank you. Got to stay away from the IT. Yeah, we met, Laura. It was really good when we met that while ago as a lead counsellor, new lead counsellor for adult social care, and I really welcome your presentation. Lots in it. I mean, I would like us to set, if we can, I don't know if we can or not, certainly an action point going forward from here to take it back into our localities, particularly Reading. I mean, I spoke to Shona and the adult social care team, and when staffing gets up, I think very much like to set up some sort of work towards a dementia strategy and working with dementia, because it might not necessarily need extra resources, but maybe looking at the way we're working, because lots of resources are going into people with dementia. I mean, I have to declare an interest in the way that my mother-in-law is getting good help, in my view, sometimes consistent, though sometimes inconsistent, help as a dementia patient. So there's lots to think about, there's lots to do. And I think rather than just us to note, which I know we're not doing, there's been lots of really positive comments, is to take this back, maybe to look at one of our scrutinies, going forward, and then working with you to devise or work towards some sort of dementia strategy. That's my views on it. So I think this is just the start of a decent, well, not so much the start, because a lot of work has gone on, but trying to draw work together, particularly in the Reading area, to make life better for patients. So thank you, Laura. Thank
you, John. I've got Katie's indicated. Was that on the back of?
Yeah, so Councillor Innes, thank you so much for that. So can I just build on what you've said there? I think for Berkshire West, we had an agreed dementia strategy, but that's probably a couple of years out of date. So why don't we use that as a basis, reflect on COVID and adapt it as such going forward, rather than starting from the scratch? Would you welcome that, Councillor Innes? Yeah.
Yeah, very much. I mean, obviously, I know Shannon's on the line and the adult social care team. I want to come in, but we want to discuss that. And that's absolutely fine by me. That, and then, apologies if I try to incur that this is year zero, because it's clearly not. And a lot of work has gone in, a lot of, good practice. And it's just maybe it's a refresh or maybe a review, relook at it. I would very much welcome, Katie, very much welcome. Thank you.
Great, thank you, and thank you for those contributions. Hopefully, you've heard the commitment. I spoke to John Ennis earlier about this, and he's very committed and keen to see to demonstrate our commitment. So the recommended action, which I think fits in terms of what Katie and John were also saying, is that we're going to take the report, the recommendations, and look at that in the context of developing our action plan, But also, I think, you know, there's the issue of the dementia element sat within the health and wellbeing strategy as a priority. Now, what we're talking about is kind of within one of the priorities, obviously it reflects on the inequality priority, but particularly the health impacts on what we're calling people most at risk. The suggestion around from this report, from developing the action plans, and we've got a real collaborative way of coming together to also look at refreshing our dementia strategy and plans locally as well. So I think that's a really positive contribution from everyone. Plus also I can see offers of support are greatly received, but particularly I'm quite keen on Joe Rice is talking about empowerment groups, particularly supports around the co-production element, which is really important as we develop our action plans. Karen, you've appeared in front of me again. Would you like to?
So I'm putting my hand up now properly. Thank you, Chair. Yeah, it was just to add on that, as we said in the committee report we sent to the Health and Wellbeing Board, the recommendation, as you say, is to embed that as part of the health and wellbeing strategy. And I think building on that conversation that's just happened with Councillor Ennis as well, is there has been great work happening. And so now what we need is that refresh, that restock, as Katie said, around what we do. And I think for us in Reading, it's best placed to sit within the health and wellbeing strategy, where a lot of work has been put into that in the 10 years, and it becomes part of that delivery plan and action plan going forward, and it gives us that governance in making sure that we do deliver on that. So I think we're all saying the same things, and I think that's where it would most make sense to sit. Yeah, no, absolutely. Okay, great. Well, thank you very much. So certainly bringing it along at exactly the right moment for us, because as you say, this is definitely what we're looking to.
Thank you very much.
Thank you. Right, okay, I've lost my agenda, and we now move on to the Fire and Rescue Service and local safety plan. And we do have Paul Inman. Here we go. Paul Inman, would you like to introduce yourself? Oh, sorry, and Gail Muirhead as well. And the floor is yours virtually.
Good afternoon. Thank you, Chair. Can you hear me okay?
Yeah, absolutely.
Perfect. Thank you. I'd like to introduce Gail. Actually, it'd be better if Gail introduced herself, but I'll just do a brief introduction. It's my first time on this meeting. Joined Royal Berkshire Fire and Rescue Service in January. And I guess my role is to manage the people, facilities, and our response to the people of Reading and of West Berkshire. So that's in terms of prevention, work, response, so the appliances going out the front doors, and also the protection work as well that we do with our businesses across West Berkshire and Reading. The LSPs that we're about to deliver are co-owned across what we call our hub, which is myself, and then we have a prevention, protection, response managers. I also have a second response manager that looks after the more rural areas and the on-call staff. Gail is one of those team members, the manager for the prevention side of things. So I'll just let you introduce yourself, Gail, if that's okay.
Yeah, sure. Hello, everybody. So I'm Gail Muirhead. I am the prevention manager for West Hub, so covering Reading and West Berkshire. All things prevention, so that includes safe and well, as well as all the wider prevention activities for road, water and fire.
Thanks, Gail. We'll try and keep this as brief as possible, just in respect of your agenda, Chair. I've got to shoot at 4 o'clock for an operational meeting anyway, so I'll whiz through these, but Gail will stay online. Really interesting to hear everybody's presentation. Well done, everybody, for the presentations, and give us that aspect on COVID and what that means for the most vulnerable in our community, which is why we attend this group. So briefly then, the local safety plans, in essence, they assist us with the effective and efficient delivery of our services and enable us to tailor our needs, tailor our response to the needs of the community across Reading. So in doing that, we look at the diversity and the makeup, the demographic of Reading Borough, and we tailor our needs in order to meet the best needs of the community. We've got as you already know, we've got highly densely populated population across Reading, and that's catered by 4 full-time fire and rescue stations at Carisham Road, Woking Road, Whitley Wood and D Road. And D Road site's currently being decommissioned and will go over to Theale around about October, November time. So with those stations, we look to do a number of operational incidents. There's 92 different operational incidents that we attend. But in order to, so on the next slide there, Nikki, thank you. No, that's fine. Carry on. That's great. Thanks, Nikki. So in order to deliver our services, we need to look at the socio-economical challenges that we have, and we know that across Reading, 10% of the areas nationally, according to the indices of multiple deprivation, that we fall into that lower area. That means we have to tailor our prevention activity accordingly. And Gail mentioned some of the activities that we do, so I'll just hand over to Gail just to give a quick précis of those.
Yep, sure. So one of the things, our key programmes, is a safe and well visit that we provide. So we aim to do about 2,500 of those, and we also do an adults at risk training programme. So that is a free training programme designed for staff that work in the community. So charities, the police, council workers, NHS, anybody who kind of works with those vulnerable people. And that goes through fire safety and also how to refer to us for our safe and well visits. So we link in with all of our partner agencies to get referrals for those people that are most at risk.
Perfect, thanks, Gail. So if you next slide, please, Nikki. So looking at our incidents. So the data set we took there from January to December is our typical annual data set, but what we noticed in COVID is our risk profile changed massively from obviously industry to the home, and that meant although we attended roughly the same amount of incidents that we did in the previous year, the risk of fire in the home increased. Due to COVID restrictions, our prevention activity was limited to those who were most vulnerable. We still managed to get out and see as many people as we could in terms of those safe and well visits. But the statistics for people in the home actually increased. So that's in terms of risk of accidental death by fire, and those who are most likely of injury from fire. So can I have the next slide, please, Nikki? So the LSPs look to analyse this data and the demographic across Reading, and we've analysed the incident trends. We saw an increase in injuries in the home across Reading caused by fire, but we had 0 fire deaths across Reading. But this information has been used to come up with a targeted safety plan, and the aim of that is to reduce those risks even further. So next slide, please, Nikki. So some of the activities that we do to reduce those are through safety messaging, and you can see from the statistic there we attended 66 dwelling fires in Reading in 2020. That's an increase, and 10% of those resulted in injuries. So in the LSPs, that's where we will put most of our focus in terms of reducing fires. And we know from our data that they are generally around cooking related and those around kitchen fires. So Gail, have you got some more information on that?
Yeah, absolutely. So we look to reduce these in a variety of ways. So we're linking with the National Fire Chiefs calendar. So they have a prevention calendar, and every month there's something that we focus on in terms of our social media. So it might be smoking, cooking, electrical fires, alcohol, all these different aspects that affect fire safety. And then, as I mentioned before, we do our safe and well visits, and we aim to do about 2,500 of those in the Reading area in the year. And those are a free service that we provide to those most at risk of fire. And we will fit smoke alarms for those that need it, fire retardant bedding, fire retardant spray. And we also visit people that are at risk of arson. So if they have been threatened, we will fit arson-proof letterboxes and also give them advice on how to keep themselves safe. We also leaflet various areas, particularly that we think are most at risk, with the fire safety at home leaflet. And then we respond to any referrals from our partner agencies.
Thanks, Gail. It's a really important part at the end there. Our referrals from our partner agencies really are our route into the most vulnerable. And out of those 2,660 is our targeted. Over 2,000 of those are to the most vulnerable, and those identified as most likely of serious injury or death by fire. Nikki, next slide, please. Thank you. So as mentioned, we work in partnership. So apart from the fires in the home, we also work with our partners in TVP to try and reduce deliberate fires and those linked to antisocial behaviour. As we know, Reading's demographic is got a lot of young people, so we aim this at education level. We believe that educating is the way forward, and in the LSP, 50% of year fives will get some kind of intervention in terms of fire safety from us in this coming year. Just a point to note, we have found it difficult to get out to our communities and to our schools. So our schools team, our education team, have produced e-learning packages that can be used by teachers at home, which has gone down really well. And there's also national material that we can link into as well, make sure our messaging is the same across the UK. So we also work with TVP on threats of arson. So we have a team that deals with safeguarding and threats of arson, and we aim to have some sort of intervention there within, Gail, you have to remind me, I think it's 48 hours.
Yeah.
48 hours, thank you. Next slide, please, Nikki. And just an example of some work we're doing. So these crime boards or arson awareness boards are erected by our staff and Thames Valley Police in hotspot areas, excuse the pun, and also we work with early intervention with the education for the fire setters' behaviours. So that's a dedicated team who deal with identified either through school or through social care, anybody who potentially, or children who are potentially likely to set fires. Next slide, Nikki. Okay, so reducing fires, one part of our job. Just in summary there, we'll continue to deliver our safe and well, and across Reading, that's around about 2,500, although our stations are fully back up to speed now, so we may exceed that this year. Continue to be active part of our community safety partnerships. As I mentioned, the education team interacting with year fives, 50% of those this year, and targeted campaigns, and the use of social media as well. So the comms team linking with other networks within your group and other areas. We utilise social media to the best of our ability. Promoting registration of electrical appliances before purchase use, and we're also involved with trading standards in terms of using our facilities for electrical blankets testing coming up later this year. Okay, next slide, please. Some of the other emergencies we attend, a big area of focus for us is water safety. So we have teams across the service in every fire station that can respond to water safety at a varying level, and the picture you see there is of our boat team at Caversham Road. But we work really closely to raise awareness of our partners around water safety. And as lockdown eases, we believe that our waterways will become more and more busy with social use. Gail, can you just expand on the water safety element that you were doing with West Berkshire and other areas?
Sure. So over lockdown, we have seen nationally and locally, unfortunately, that the number of drownings has gone up. And I think that's because people haven't been going on holiday and they've been making the most of, our local waterways. So we're working very hard to promote water safety as much as we can. We've looked at the data and analysed that, and again, nationally and locally, males are more at risk of drowning, and one of the key factors in that is the alcohol is a factor. So we've done a Don't Drink and Drown campaign, and we've been working in Reading with some of those local pubs that are along the waterways with, don't let your mate walk home, along the waterway alone, just be mindful of the risks, etc. And that went down very well. The pubs were very, very receptive and very helpful in raising that awareness. And obviously we've put that on social media as well. The other risk we have is of young people jumping off of bridges. So we have a What's Under the Water campaign, and it has a photograph of some things that were pulled out from Caversham Bridge. And partly it's to help them think, what are those risks and what might you be jumping onto? So we're doing some work with youth workers and any other partners that will work with us on that. The other thing we have done is we've set up a water safety partnership with West Berkshire, and that's gone down really well because we've had SCAS, TVP, Canella Waterside Trust and all relevant partners, and just to kind of throw that out there, that would Reading potentially be interested in doing a similar water safety partnership? So perhaps something to discuss outside of this meeting.
Thanks, Gail. Next slide, please, Nikki. And one of the other main focuses of the three within the LSPs is around our continuous support for road safety, mainly led by TVP, but in partnership with those, we share vital safety messages. We use our education team to best effect to deliver those safety messages around young drivers and speed limit adherence, and also drink drive campaigns. We also have a static display outside one of our stations at Wokingham Road that shows a car that we've cut up, which is just a hard-hitting sort of visual display, really, to show some of the dangers of not driving carefully. And we also support the Brake Annual Safety Campaign. Next slide, Nikki, thank you. Which I think is just contacts. It is, okay. So there's some of our contacts there. It's a bit of, Chair, it's a bit of a whistle stop tour of the LSP, but we're more than welcome to come back and let you know how we're getting on with progress when you've got a less packed agenda. Just in terms of COVID, we've managed to keep all of our frontline appliances on the run, as we call it, during COVID. In addition to that, we've kept 9 ambulances on the run with drivers supporting SCAS as well. Thank you for your time. Willing to take any questions. Gail will stay on. I will depart after questions, if that's all right, Chair.
Yes, of course, and thank you very much for that. I think that was. I would like to say you're really very much welcome as valued members of this board now, and actually going through this presentation just goes to show exactly why, the contribution you make and the partnerships that can happen. So yeah, I was interested in the water safety partnership, so I could understand that was set up in Newbury, West Berkshire. It was a particularly tragic accident, so I think that's something we want to explore about how that's going, see how that's working, whether that be something that could be a good idea to take on here in Reading. It would seem obvious with the amount of waterways we've got running through, the town, that would make sense. So thank you for that. Right, any questions? Any points anybody wants to raise? I haven't got anyone indicating. It was a fairly, people may well indicate as I just carry on talking. Perhaps I need to be careful about always wanting to fill silence with Mr. I do have one question, and that is obviously previous to pandemic, pretty much one of the most popular attractions at most community events was a fire engine, and a lot of good work being done around fire safety from members of your teams, events all across Reading. Obviously, that's not really been possible more recently. We may get back to having more community events, but I wonder if you'd had any other sort of alternative solutions whilst you've not been able to be, sort of in person at events like that.
Yeah, it's a very, very good point. It's been difficult. Let's be honest, it's been difficult to get out. Our main engagement with our communities is to go out and do that, and we haven't been able to do that as much as we'd like to. But we are rewriting our risk assessments. We're rewriting some of our packages. As I said, we can reach out to our schools electronically now. But more importantly, we're just about to, it's in the LSPs, we're just about to put some community engagement advocates on station, which are people who will focus some of their time on looking at new ways to reach out to groups within the community. Some that have formed during COVID electronically, some that maybe we've lost touch with in COVID, and some new areas as well. We're really keen to make sure that we hit the diversity within Reading and make sure that we can connect with every group. So there's a renewed focus on that, I would say, Chair.
Sorry, I just muted myself rather than unmuting myself. Right, I haven't got anyone else indicating. So, right, so clear. We'll take away that action, that offer to discuss a potential water safety partnership for Reading. I think that's really seems a sensible thing to explore. And you can see the obvious benefits that can have for this town. And also, I guess, maintaining those links is really important. You've got how you can partner with us. We really need to make sure that continues, and those effective partnerships and working together continues into the coming year as well. So I don't have anyone else indicating. So thank you very much for coming along and presenting that. And yeah, thank you.
Thank you, Chair. Thank you, councillors and invited guests. I've got to check out now. I'll leave you with Gail. Thank you.
Great. Thank you. Thanks very much. Okay, let's move on then to the next item, which is an update on the Berkshire Wells health and wellbeing strategy. David.
Great. Thank you, Chair. So in the interest of time, I'm going to take the paper as read and aware that members of the board have had updates in each of our recent health and wellbeing boards on the development of the strategy. So I'm deliberately not going to go through the context and the background. All I want to say is that we have, as I'm sure people will be aware, we have identified 5 priority areas that the strategy will focus on. So that's around inequalities in health. It's about supporting individuals at greater risk of bad health outcomes. It's about helping children and families in the early years of life, the best start in life. And then there's 2 around promoting good mental health and wellbeing, 1 within children and 1 within adults. So those are the 5 priority areas identified through a process which you can read about in the report in more detail if you're not yet kind of cited on that. We're currently in a period of kind of formal public consultation to show those priorities, the draft strategy itself, the context for us in Reading and Berkshire West, because you'll recall this is a strategy across the west of Berkshire, not just a Reading one. due to the extent of consultation and stakeholder engagement we've done before this formal consultation, we're not anticipating that the outcome of the consultation will dramatically change those priorities or dramatically change the shape of them, or the shape of the document, should I say. So what we're doing currently is working on the action planning and the delivery groups that would sit under those 5 priorities to answer the question, well, what does this mean for Reading? What will we do to deliver against those priority areas, to deliver the strategy? So we're doing that kind of planning, delivery planning work, whilst then waiting for the consultation to complete, which is in early August. We then will bring that all together, and then the plan is to have a full strategy for this board to be able to review at the meeting in October, with the hope that that would be agreed by the board. Clearly, we'll have the discussion in October, and then we'll be able to move forward with the work of delivering against it. I think it'll be a good strategy for Reading. It will pick up on what we know our priorities are, and very much with the view of kind of recovering from COVID in mind. So that's really all I wanted to say, but happy to pick up any questions or comments about it if anyone has any.
Yeah, thank you, David. And yeah, hopefully people have had a good look. I thought the engagement document was particularly interesting. And as David says, this is out to public consultation. If you haven't read the latest strategy, have a read, and I guess people know how to get hold of the public health team if they'd like to. I think the details are on there as well, who to respond to if you have anything you'd like to.
And I'll post the link in the chat as well, if that's helpful,
great,
so that people can see where the consultation bit is and
rather than emailing you, David, which I realise is a danger if you did say that. Okay, does anyone have any questions, any points? I think that's fairly straightforward. If anyone, publicise that as well. If people think people ought to have sight of it, that you know, in your partnerships and in the community. So I'm not seeing anyone indicate, David. So I think that is perfect. So thank you very much. Okay, next item is Hanging On, which I love the title too, and that's the Health Watch report on GP phone access. Do we have Mandy Baines?
You do.
Hey, okay.
Sorry, Nikki, am I able to upload my presentation? Sorry, Nikki, I didn't get that.
Sorry, I just realised I had my the thing, but not by my mouth. Yeah, if you could just share your own screen, or I could share it and you could then take it over, whichever you prefer.
If you share it, I'll take it over. Thank you.
Okay, hang on a sec. Let me just open up yours as well. Hanging on, here we go.
Sorry about this. My fault.
So...
Should have called a comfort break or something, but I think we're nearly ready to.
Is that there now?
Yes, it is. Thank you. And I can be controlling that, can I?
If I think it says there's something that somewhere you should say you can take over presenting or something.
Does it?
In your Teams thing.
Oh, I don't have full access. Let me try. Sorry about this, everyone.
If you want, I can just do it for you.
That'd be great. Thank you, Nikki. Thank you, everyone, and thanks, Nikki, for sharing the presentation. If we could just move on to the next screen, that'd be great. Okay. So we carried out this piece of work because of the large amount of feedback our board members had been receiving from local people struggling to get through to their GP on the phone. Therefore, we conducted an online survey and received 339 responses with the aim to understand any struggles accessing GP services as the country eased out of lockdown. What was clear was a strength of feeling that came through on the comments left by respondents. Therefore, we feel the best way that we could think of to articulate their feelings was for them to speak for themselves. So Nikki's going to kindly play a series of short anonymised clips, which are comments from the report. Sorry, Nikki, you'll have to go turn by turn. Sorry, Nikki, you've got to click on the speaker and press play for each one once it's finished. So just got to start with the top one, yeah. The little speaky sign next to the name.
It was actually playing for me. Was it not playing for you?
No.
No.
Ah, okay. Did you hear that?
No.
Okay, I wonder why that is. What else needs to happen for that to work then? Because I can hear it perfectly.
Apparently you need to share sound.
Oh, okay, where's that? Let's have a look. Anyone know where that is? Not had this one before.
Sorry, Nikki, I can't help too much with this.
Nick, it's normally in the share content bit, isn't it? But I
I haven't done sharing sound stuff before, so let me just.
I may be thinking of Zoom, so I might not. Perhaps I ought to shut up.
Let me just see what it says. Oh, hang on. Here we go. Include
Sound,
the sound. There we go.
Thank you.
Right, is that all there now?
You could try playing one, Will.
Yeah.
Thank you.
Certainly sounds a bit noisy. Sorry about this. Take that back to the beginning.
No. That's okay, Nikki.
Did you hear that?
No.
You couldn't hear that?
No.
Oh.
That's fine, Nikki. Thank you for trying. I'll read some of the comments. Thank you.
Yeah, sorry about that. I've no idea how to do anything more than that.
Perfect. Thank you so much for trying. Okay, Nikki, if you mute, I'll carry on. And okay. Thank you. Apologies that the presentation doesn't work, but if you bear with me, I'll just read a couple of case studies that have been illustrated within the report, which I'm sure you've read. The first is from an 80-year-old lady. So, I am in my late 80s and I have been with my practice for decades. Until the COVID crisis, I had been unreservedly in praise of my surgery, dedicated, kind, and expert practitioners, and no delay in testing, diagnosis, and relevant treatment until my latest predicament. I have been waiting for a month for any investigation for debilitating symptoms, including a marked loss of weight. I had to try repeatedly to phone at the stroke of 8 a.m. and either gave up in despair at the constant engaged signal, or I did not get through hours later. All on the day bookings were taken. I finally was put on the list for a duty doctor who took immediate action to arrange a blood test and refer for an investigation. After further delays and waits for forms, a friend phoned the surgery on my behalf, and I finally got booked in for the appointments I needed. I'm writing this saga more in sorrow than in anger. I am fully aware of the overwhelming pressure primary care is under. I have a GP in the family, but the long wait for communication with a doctor has been markedly deleterious to my health and well-being. I'd like to share another one with you, please. This is Jake. I called with regards to my 9-year-old son to get advice on a walking foot issue, which was not improving after 3 days. GP took 2 hours to call back, and despite me clearly describing issue and saying no trauma injury, it was as if he was not interested in actually seeing us, just advised to go to RBH A&E for minor injuries. Went to minor injuries where we were seen by a very efficient nurse-led team. It turned out that the issue could have been easily diagnosed by a GP if they have actually seen us and not tried to make a rush decision. Not sure telephone triage is the answer. I'm sorry, I have just one final one to share with you. This is Sue. I am a frontline NHS worker in a hospital and have worked throughout the pandemic. I've seen patients face to face, spoken kindly to them, and made sure they could still access care. I wanted a booked appointment for my toddler to be seen with an ongoing and worsening issue. I was spoken to like I was foolish, told I could not pre-book any appointments and had to call on the day. I explained I worked every day and would be unable to call at 8 AM and attend the same day as I was at work in an acute setting. I needed to pre-book to be able to arrange to leave work and pull my toddler from childcare to attend. The receptionist put me on hold. On returning, she advised me on this occasion and emphasised it would not happen again under any circumstance. The practice manager had agreed that I could be put on the phone list for a telephone call the following day between 8 and 9, but that they would not see my child. The call actually came at 10:30 when I was working, so I had to interrupt my work as I had expected it earlier. The GP spoke to me and arranged a referral for my child to the hospital. I cannot understand for what reason GPs are not allowing patients to pre-book appointments anymore and are still refusing to see patients face-to-face for thorough assessments. This wall of obstruction is appalling, and with improved understanding of and the falling rates of COVID is no longer excusable. Sorry, Nikki, can I go on to the next slide, please? Those were just some of the comments that really illustrate some of the strength of feeling, but there were also many positive comments that were left about professionals and services, and they were all listed in the report. Next slide, please, Nikki. In addition to the voices, so there were 221 comments were left by 339 individuals. They focused mainly on the lack of online booking, delays in getting appointments, the lack of face-to-face, and the manner of receptionists. The other main findings from this survey showed that the vast majority of people calling the surgeries were put on hold, and a fifth got an engaged tone. Nearly half got through within 10 minutes, but 15% had to wait over a half hour. A third of respondents were calling to book a routine appointment and a quarter an urgent on the day appointment. Just over half described the experience of calling their GP difficult. We then saw a further trend in people's experiences. Half the people living in central or south Reading said calling their surgery was difficult. This compared with around 30% in north and west Reading, reporting that their experience was difficult. This inequity of experience has been a long-standing issue in Reading, and I feel it tells us two things. Firstly, that there may be some good practice in North and West Reading that needs to be shared and learned from. And secondly, we should be very concerned that the populations that suffer the most from health inequalities are amongst those living in South and Central Reading areas, and they are the ones reporting poor experiences. Next slide, please, Nikki. One of the other issues we wanted to highlight through this report that came through in the comments was how mixed messages compounded the pressure on phone systems. Many people reported that online booking had been switched off for routine appointments, forcing everyone to call the surgery. Phone systems were simply not set up to cope with this level of activity. This means people give up, and this can be detrimental to their health. However, in pre-COVID time, surgeries had been trying to meet national targets set to increase online activity and appointment booking. In addition, the NHS app is more popular than ever, and locally, digital health champions are currently being recruited to encourage more online access. However, all these efforts seem wasted if the only message is to call your surgery on the phone, which seems a little bit like a step back. So, sorry, next slide, please, Nikki. So what did patients want? They wanted three things, really. They want online access brought back for those who are able to use it, opening up the phone lines for those who are unable to use it. They want a timely, responsive service so their health and well-being does not deteriorate and potential serious conditions and illnesses do not get missed. Finally, they want to see their GP face-to-face, whereas telephone appointments, as has been reported today, may work well for some. Many wish that face-to-face interactions are beneficial to help articulate how they are feeling. And an important message from this report is that they want that face-to-face interaction to increase. From a Healthwatch Reading view, we have not to date conducted a survey where such impassioned comments have been received. And I feel that those impassioned comments really need to be heard, and actually we need to use that to move forward with understanding and access and increasing access to GP services. So apologies for the technical errors, but I'm happy to take questions or you're on mute, Graham.
Sorry, I'm on mute. Thank you. Yeah, so I do have a couple of questions, and others may haven't indicated, but I wonder if it's worth taking the response first, because that may answer something or not. And I have got Sarah White indicating, so that's excellent. Sarah.
Thank you, Chair. So, Mandeep, I was just going to respond to the report, but firstly to say thank you for Healthwatch for running the survey. And you're absolutely right. Some of the personal stories that come out of it have been eye-opening and have been really valuable to the CCG. So we are grateful for doing that, for you for doing that. I mean, some of my responses to it, you know, the formal CCG response is part of the report that that Healthwatch has shared with the committee today, with the board today, and also we've responded to it in responding to Tom's late question today around work that we're doing to improve telephony systems within GP practice, and also our GP lead Andy referred to some of the work that we're doing in his presentation today, also around our response to COVID. But generally, I mean, some of the sort of high-level things that we are already doing to try and respond to the issues that have been raised. So we're working to ensure that 111 is used more effectively, and that 111 call handlers are able to book into appointments into GP practice. So we think that that would help relieve some of the pressure on GP telephone lines. So we're also working with our PCNs and around establishing referral pathways to pharmacists and providing community pharmacy consultation services. And again, that it will be another route which patients be able to go through to access services. We're working with our communications and engagement team around a sort of communication campaign covering self-care, the role of pharmacy, sort of help us help you, promoting the NHS app, all the digital sort of awareness work that we need to do, and the digital champions work that Mandeep has already referred to. We've done an audit of all the practice telephone messages, and as a result of that local audit that we've conducted, we've issued a standard sort of generic shorter message that we're hoping our GP practices will adapt, and that will mean that patients are having to, we hope, will to wait less time on phone lines. We're looking at scoping and providing training for receptionists and also to the GP practices around managing activity and demand. And also working with practices at the moment to ensure that they are opening up and that the patients are able to go into the sites and book appointments at reception, again reducing the demands on telephone lines, and also around increasing online bookings to also reduce the.
Sarah, you've muted just a few moments ago.
Sorry, sorry, Councillor Hoskins. I was just saying that it's just a bit of summary about what actions that we're trying to take at the moment to respond to the report, which has been really helpful. And just one additional thing. So Healthwatch were kindly shared with us individual practice survey outcomes. So as a result of that, we've identified 8 practices that we're currently working with on an action plan about what they can do in-house to address the impact and the outcomes of the survey. And we've asked those 8 practices to do that in consultation with their patient participation groups. Thank you.
Thank you, Sarah. Do you have any questions or any points anybody wants to raise? I haven't got anybody indicating. I do have a couple of very quick questions. Well, a point I think in terms of the inequalities point I think is really important. Obviously, the inequality of primary care access is something that's important to address and has been over a number of years, and so it's just sort of come out I think a little bit in this work. I think one of my experience, this is a personal experience over the last few months, is that and I think there's clearly variation in how different practices are working, so that's something we need to consider and learn from better practice, is that the system does seem one that if you are switched on to dealing with bureaucracy or working your way through it and also have time to spare, you can work through it and get good results, which I certainly managed. And I worry that people that have work commitments that are very rigid and can't be about for phone calls back and also perhaps are not quite as sharp elbowed in order to secure their own access. I think that's a real concern. So I think that's something that I particularly want to see looked at. And I think and so as I said before, there's a piece of work around access to primary care, and I think it's as we move out of the COVID pandemic, and there's considerations of new ways of working, that's something that I want either the board or maybe the council's scrutiny. I haven't completely thought about which way that would be the best thing to go, but certainly a report about how that's developing and the interaction of involvement of the council partners and the public around how that develops, I think will be really important. So I want to take that away as something to sort of set up. Which I said at the beginning. So if that's sort of my commitment, I think, in terms of that, because I think the strains that primary care was under anyway before the pandemic, and moving to new changes, I think is something that's a really important area, and it's really important that people don't feel shut out. And so I suppose, and I think also it's really important because I think my concern is that we don't want a system that does end up pushing people into A&E in secondary care, because obviously that would be impossible to cope within the system, extremely important and not good use of resources. So I haven't got anyone else indicate. Thank you very much. I don't know, Mandy might want to sort of summarise because it's also her report. Thank you very much for the Sarah for presenting the response, which I think there's some really important stuff in there. But I think the general access issue is something we need to pick up and take up on a partnership basis. Anyway, but Mandeep.
Yeah, thank you, Chair, and thank you, Sarah, for that response. We're really pleased that the report is being used positively to really influence and start to bring about change. And certainly, you know, I'm sure the public are aware of the pressures across the system, but also we can't forget that, you know, the public has been sent several messages, and one is that you must get in contact if you are unwell, and they are using the channels that they know best. So there is a thing that has been ongoing throughout the whole COVID pandemic, which is around that clear communication with the public in supporting them to make the best choices, but also to fully recognise that people not getting through to their GPs is a very, very real thing that people experience every day. Even now, we get phone calls from people saying, you know, I just can't get through, and it's making their mental well-being deteriorate as well as their physical condition. So they're making the choices that they feel best, be they right or wrong, I don't know. But we are really pleased. I think, Sarah, if I was going to come back on one thing, is I think we'd like to know more about the increase, about opening up online appointment booking again, because knowing that that actually does work well for some people, that could be certainly an avenue where some pressure is taken off, as well as all the other efforts you have outlined. But no, I'm really pleased that it's having an impact, and I hope we can continue to use it to do in that way.
Okay. Thank you, Mandeep. So you've appeared again. Was that just?
I just wanted to acknowledge what Mandeep was saying, that I was listening, and we would definitely engage with you further around the online booking arrangements. Thank you.
Great, thank you. And thanks for that, Mandeep. It's a really important report. Unfortunately, we've got quite a lot of really important items and packed all into one meeting. It's quite a challenge tonight, but thank you very much for that. The next item is also yours. It's your annual report, Mandeep.
Okay. Thank you, Chair. This is just a very quick run through, and I hope it's it's a short and concise annual report, so I'll give a short and concise presentation. So as for many organisations, it was a year of doing things differently and making sure we were connecting with our community effectively. And we are grateful to all those volunteers and our formidable staff team who helped support local people over this last year. It was a very busy and diverse year for us. We started the year supporting the local COVID effort, supporting vulnerable people, but also by providing essential information and advice on COVID. We also channeled a lot of information through social media channels, answering questions and signposting people. As a result, this has been our busiest year for providing information and advice. We also supported the drive to ensure our communities, in particular those who go unheard, aired concerns about the COVID vaccine and were able to overcome their hesitancies. Our work with vulnerable communities continued when we helped asylum seekers placed in a Reading hotel to access urgent healthcare. We completed a report and will ensure the lessons learned from that report are put into action with the new hotel. We also completed a survey on people's experiences during the first COVID lockdown and heard about people's fears about accessing services and the need for better, clear and timely communication about services. Finally, we continue to use local people's voices to influence the commissioning and delivery of services as our local commissioning structures change over this year and take place more at a regional level. Therefore, we are working with partners across boundaries to ensure voices of Reading people are heard. Thank you very much, Chair.
Thank you, Mandeep. And yeah, it's a shame that this report's packed into such a busy meeting, but it's a really good read. If you haven't read the report, I highly recommend it. I'd just like to thank yourselves and your team for the work you do. And I think particularly is just the general flexibility and responsiveness to the situation and things that have arisen over the past year or so, and just responding to those is really important as well. Obviously, in the past year or so, it's been demonstrated. So thanks for that, and also being such an invaluable, you and David personify that, but such invaluable members of the Health and Wellbeing Board as well is really important. I haven't got anyone else indicating, so I apologise. It is an important report, Mandy, but obviously we're having a really busy meeting, so thank you very much for that. We then move on to the update on the mental health crisis cafe. I think you had Nikki Cart, right? Yes. Hi,
yep,
Nikki.
I'm here. Thank you very much, Chair. Just to say, we're absolutely delighted that we were able to award this contract to a voluntary sector organisation, and the service will open at the end of September. Although the actual start date of the contract is, it's commenced in July. The premises are going to be in Friar Street, so there was a requirement that it was within 15 minutes walking distance of the Reading train station, and there's work in progress to furnish that, and people with lived experience are being involved in that process. The Breathing Space Cafe will be open each Friday to Monday in the evening, so probably 5 p.m. to 11 p.m, and will include bank holidays. Services for adults, and it's for all three of the local authority populations across Berkshire West, so Reading, West Berkshire and Wokingham. It will offer short-term crisis support to people who've been advised to attend by a professional, or for people who want to get in touch directly. There'll be a minimum of 3 non-clinical staff at all times at the premises, and the service is also open to and encourages additional volunteers. That's seen as an important part of the service. The staff who will be employed by the Breathing Space will have direct access to the crisis line and mental health practitioners at Berkshire Healthcare Foundation Trust, which is great because that gives them access to professionals if they need help and advice. So I don't think there's anything more I wanted to say. I think the report is comprehensive, but I just wanted to pull out those key points for you. I'm obviously very happy to take any questions.
Yeah, no, thank you, Nikki, and it's great to see this update. It's something that we've been wanting to see for some time, and it's great to see it finally nearly arriving.
Almost there.
Almost there, yes, exactly, very close. I haven't got anyone else indicate. Oh, hang on, we've got David Monday is indicated. David.
Yeah, I mean, it was just simply to say, Chair, how welcome it is, and particularly as we're moving forward with the health and wellbeing strategy, which I kind of just touched on earlier, where we know we need the focus on mental wellbeing as 2 of the priorities that residents are telling us about. It feels very timely. Clearly, this isn't the only bit to delivering better mental wellbeing kind of locally, but is, an important kind of string to the bow. So it was really just to kind of echo comments already made about the welcome progress.
Yeah, no, absolutely, David. So yeah, okay. Well, thanks very much. Hopefully, I might be able to get down and see how it's going come the autumn. Thank you very much, Nikki, for bringing that to us. Right, the next one is the Care Quality Commission. Finally, nearly finishing off our reports and action plan closure. Does anyone? I'll assume that people have read this, so it's kind of an information item, but obviously we need to agree on the action. Who's presenting? It was Shona, but she's not here. Nobody is coming forward.
Sure, I thought Melissa would be if she's representing Shona, but is she still around?
I am still here.
Melissa, hi.
I suppose, yeah, really happy to go over it. But as you said, Councillor Hoskin, I thought it was an information report and kind of speaks for itself. I guess we're really keen to close this off. It was a while ago, but it's a really positive outcome in terms of the learnings from that system review. and that despite COVID, some of the actions that were outstanding have now been completed. So unless there are questions, I wasn't going to add anything further.
No, that's great. I mean, people may have questions, but I'm not seeing anyone. The important thing is that hopefully people have read that and are happy with the actions, which is, well, we're noting it, but is that we're done and we've completed it and we've met it and we've sent it off. Now is the time for someone to say no. I'm not seeing anybody saying that, in which case I'm not sure I should say this. I may even I was thinking about opening. I forgot a bottle of something bubbly in my fridge. Has been going on for so long. It's great to see it. Great to see it done. Thank you, Melissa. Right, I think you're next, Andy.
Yes, thank you, Chair. So I've been asked to present on behalf of the CCG just an update from the ICP Unified Executive, the June Chair's report. Very briefly, there's just 3 items just in the paper just to highlight. One is about discussions within the ICS Systems Leaders Group, that's the Integrated Care System at BOB, which is Berkshire, West, Oxfordshire and Buckinghamshire, for those who don't understand the acronyms. So this is where the new CCG will sit in April 22 as the 3 CCGs merge into the ICS. There's still some debate about the actual geography of the ICS at the moment, so progress on getting new staff employed for the ICS team is sort of slightly on hold. They're sort of in interim positions at the moment, and at some point hopefully there will be a managing director for each of the 3 places, so that includes one for Berkshire West, who will be sort of in charge of what is going on at place level, which is sort of at the Berkshire West level. So we're still waiting for final decision from Department of Health, and then we can crack on with the formal employment of the statutory body team. In terms of ongoing work for this year, 21-22, there are some ICP priorities. They're mentioned in the paper. 5 of them have been chosen for focusing on aging well, cardiovascular disease, workforce, emotional health and well-being for children and young people, and learning disabilities and autism. So that sort of dovetails quite well with quite a few of the priorities coming up in the health and well-being strategy. The cardiovascular disease one is specifically a public health initiative. So the projects are sort of being worked up, and they're being approved for the work for this coming year. The future development of place, as part of the government's white paper, some of the aim is for the ICS is to delegate responsibility for some aspects of care below the level of the ICS down to place level. So effectively, although the CCG is moving up to the level of BOB at the ICS level, as it will be from April next year, I mentioned earlier, some of the work they'll still want to happen at the local place level, which for us is Berkshire West. There was a workshop in April to look what would be a good initiative to work on in terms of delegation, and 2 were picked out. One was aging well, which is specifically around the urgent community response that the BHFT, in conjunction with social services and the Royal Berks team, are in charge of doing, and also urgent care, which is also a big partnership piece of work with everybody from social care, from health, from leaders of the local authorities, with the ambulance service and primary care, trying to keep urgent care on the straight and narrow. As we had heard earlier on, demand is up, the ED is busy, and there's a lot of challenges to make that happen, as well as with winter coming. So there has been some work done on that, and there are certain challenges with getting delegation, but at least we're ahead of the game in terms of preparing for that if the ICS chooses to use that opportunity. I hope that summarises the paper. Thank you.
Yeah, thank you, Andy, for that. And that's for that. I don't know if any questions, any points anyone wants to raise. Oh, what I would just say is I think the ICP and this Berkshire West holding together will be incredibly important, because with the NHS reorganisations that's happening, we know we will lose our CCG, and there will be kind of, you know, therefore how we work together in order to make sure that we actually have locally responsive and you know, connected locally planning and integration. It's really important we make this work. So I think that's what I will say. No matter where the actual footprint goes that we sit within, in the end, it's really important that we make this work. So thank you for that. I don't have any questions. I think perhaps what is occurring to me is we probably do need to make sure that when things settle, we bring back how we're going to work within the new system, and that comes back to this board, because that will be a really important element of how we our future, basically. So
yeah, I mean, I because of the change in health minister, I think some of the decision making has been delayed, so I'm hoping that by our next meeting in October, the boundary issue for the ICS is resolved, and the ICS will have moved on with what they need to do. Thank you.
yeah, no, that's right. There's a few things in the health bill which are sort of up for challenge, and we don't know what quite will go through or not. So that'll be important as well. Thank you very much, Andy, for that. I haven't got anybody indicating, in which case we move on to Better Care Fund end of year return. Hopefully people have read the report. Bev Nicholson.
I'm here. Thank you, Councillor Hoskin. I'll keep it brief because I know we're short on time. Would you like me to share on screen? I'll just share the report here. Hopefully people have had a chance to read it, but this will be a very brief run through. BCF end of year report, here we go. So this is an end of year report for 2020-21 that we have to submit to show how we've spent the funds for the Better Care Fund that we get on an annual basis. And there are 4 national conditions that we have to demonstrate that we've met, and we did meet them all. We submitted the report by the return rather by the 24th of May, which was the deadline. And obviously we're asking that that be noted by the Health and Wellbeing Board, who are responsible for oversight of the Better Care Fund and the returns.
Bev, I don't think you've shared the actual report. I think you've shared something else. At least I can't see it. Can anyone else?
I sent this report in.
No. You just said you were sharing something on screen.
Oh, okay. Apologies.
Were you sharing something on screen? Were you trying to share something?
I think I'm sharing something on screen. It's saying I am.
Yeah,
okay.
I don't think you shared the report though. All we can see is your name in a circle. So I think you must have shared a different window.
There we go. Can you see it now? Everybody see that now?
No, I mean, people do hopefully have access to it.
Oh, that was interesting because it's saying stop presenting at the top of my screen. So I have an option. So I'm clearly presenting to somebody, but I'm not quite sure who. Anyway.
No, you are presenting something, but you're not presenting the report. I think you've presented a different window that you've got open.
Okay. I'll just stop sharing then. And I'll just talk us through the report, given the time that we've got available, if that's okay. So the main points to note really are that we submitted the report on time by the 24th of May, and the 4 national conditions were met. And the first one was about making sure that we had what's called a Section 75 agreement, and that signed off with all the system partners to pool funding that we then use for integrated services. So that Section 75 agreement was signed off within the year. There's a contribution to the social care from the CCG, a minimum contribution that's ring-fenced, and that was made. The minimum contribution was made, and in fact exceeded. It was 10.6 million. The third national condition is that the spend on CCG commissioned out of hospital services must meet or exceed the minimum ring fence. for out of hospital services, and in fact the minimum ring fence was 2.7 million and we spent 5.1 million, which was in line with our plan for 2020-21. And then the fourth one is just that the CCGs and local authorities confirm that compliance with the above conditions to the Health and Wellbeing Boards, which is what we are doing, and so that is confirmed. Really, that's a whistle-stop tour of the BCF report, but I'm happy to answer any questions anybody might have, and we did include the actual return as an appendix to the report that was submitted.
Thank you, Bev. Any questions? I mean, obviously we always have this point in terms of the timetable that we have to follow for this doesn't fit our you know, the way this board's run. Any questions or anything else? Hopefully people have pretty much cited it on how the process has been working beforehand anyway. Okay, great. Thank you, Bev, for presenting that.
Very much. I think the next one's mine as well, actually.
Program.
So I'll try and present this one. We'll see if you have any better luck. Wellbeing Board. Here we go. Integration report. Can everybody see that okay?
No, I'm
it's
afraid.
still not presenting. Oh, how bizarre is this? Okay, I shall.
Never mind. You
that. Okay.
Well,
so highlights again. Whistle stop tour. So we have so the integration report focuses mainly on the Better Care Fund high level targets. We've got 4 of those. We met 3 of them by the end of the year, and one of them was just slightly under. So the ones that we met were the non-elective admissions targets and the admission to nursing and residential homes. They were all well below the target that we were set. And we also met the discharge to assess in our discharge to assess flats. We had a minimum number of 18 people being going through that service, and we met that target. The one that we missed was the reablement 91 days. Now, this is a target that looks at when people look from the date that people are discharged from hospital, where they're receiving reablement service, are they still at home 91 days after they've been discharged from hospital? And sadly, we missed that target. The target is we got 76%, so 39 out of 51 people in that period who were still at home. And sadly, 5 people passed away, so that had a significant impact on the overall figures, and 12 people were readmitted. So we're looking at the period from discharge from hospital in January, still at home in April, basically. So that's the 4 BCF targets, and then we went on to discharge to assess. So our discharge to assess pathways, which we talked about at the last Health and Wellbeing Board. We started monitoring and measuring this data from October, so we now have 2 quarters worth of data. The concerns that we have at the moment are around lengths of wait for discharge. So on Pathways 1, it's about 3.4 days. And that's home with a care package. On Pathway 2, it's 1.4 days, which is up to community beds. And on Pathway 3, which is the most complex pathway, it's about 10.6 days, and that was for the period to the end of March. So the data is being updated all of the time, and obviously for the next quarter, hopefully we'll be reporting an improvement on that. And we're performing reasonably well actually against the overall discharge pathway targets, with having achieved the 91%. In fact, we got 92% of people going out in Pathway 0 and Pathway 1 in total, against a target of 91%. And the areas that we're a little bit under is where we've got Pathway 2. We're expecting to have less than 8%. So less than 8% of people going out on that pathway. Actually, we achieved that. We got 6%. And Pathway 3, we had 2% of people going out on Pathway 3, where it should be less than 1%. So it's not a million miles away, and we've got room for improvement, and we're certainly working towards that. And the maximum number of people entering residential nursing care after reablement leaving the reablement service was only 18 against a target of 116. So we're very pleased about that, that performance. The average length of stay with reablement services was 3.32 weeks against a maximum of 6 weeks, which is great, and it frees up capacity within the system. The accelerated integration payment that we get in addition to the BCF funds reablement services, so it's invested into the reablement service, and that increases in the number, and so that led to an increase in the number of people receiving a package of care. So in 2019-20, for the same period, it was 568 people, and for the same period in 2021, it was 588 people, so it's increasing. And then the Reading Integration Board programme plan has now been agreed and was appended for information with the report. And we've also got an identifying column that identifies key priorities around the ICP priorities and also the emerging Health and Wellbeing Board strategic priorities. We've highlighted in our programme report the priorities for the integration board, and that's multidisciplinary teams, so getting those to wrap around the PCNs, discharge to assess service model for Reading, and community reablement team reviews, as well as the Nepalese diabetes project. And as I say, these will be mapped to those priorities at ICP and Health and Wellbeing Board level. And we're also leading, so Reading Integration Board are also leading on the local action plan for the Health and Wellbeing Board emerging priorities 1 and 2. So priority 1 was to reduce differences in health between different groups of people. And priority 2 is about supporting individuals at high risk of negative outcomes to live healthy lives as a result of those inequalities to access. Accessing services, which have been discussed in quite a lot of detail in earlier reports. Actually, we're working very closely with our integration board members. So that's a whistle-stop tour. And one thing just to add to that actually is we are looking at implementing a new model of discharge to assess in Reading. More to come, watch this space. It's quite exciting, and we do think it will make a huge difference in terms of really managing these the flow from hospital and also admission avoidance from the community. So that's my report. Thank you very much, Councillor Hoskin, and happy to take any questions.
Thank you. Obviously, people have got the report to read. Any questions? Anybody? Any points anyone wants to raise? No, that was quite a good run through, Bev, so thank you very much for that. As we note, the progress made, I think, was the action, so thank you. Right, our last sort of substantive item, Health and Wellbeing Dashboard. I think, David Monday, one of your last acts, David, in public for us, sadly, sure. It's going to be the dashboard. David. Yep.
Thank you. And it always feels like it's left to the kind of the last item on the agenda, isn't it? But I know it's an important one and one of interest. So it was. I'll assume that people have taken the opportunity to read the dashboard report. So I just want to draw attention to a couple of just highlight points. Firstly, for those that have read it in detail, you will note a typo on page 376 because we've talked about the current position and an update for March 2020. I'm not quite sure how we managed that. It clearly meant to say July 21. So apologies about that. But the Appendix 1 has got the kind of the one-sider, which has got the kind of summary of where we're at with the targets within that we are measuring ourselves against to show our action against the current health and wellbeing strategy. So the things that are different to the last time you've seen this report are on our the proportion of adults that are overweight or obese, and then about physical activity levels. So both of those we meet the target on, although actually the obesity proportion obese has got a bit worse compared to last time. Interestingly, neither of those data yet take into account the time period when lockdown started. So it's actually 1920 data. One of those indicators quite delayed in when it comes through. So what will happen next is understanding in a bit more detail the impacts of lockdown on those two aspects, so on weight and on physical activity, that are clearly linked. Updated every quarter is our performance against NHS health checks, which is suboptimal, and the reason for that is clearly because of primary care. We've been talking about already in this meeting needing to prioritise various bits of work, and the health check programme has not been the #1 priority. We are, and Katie alluded earlier to the Reading Integration Board, we are commencing a programme of work to kind of relaunch the health check programme and to target those those who will have the most to gain from having a check. And we heard earlier about the importance for that in dementia prevention, along obviously with other things. So clearly work on that needs to happen, but we understand why performance isn't as we'd want it to be on health checks. Then the other three things that are updated then. So we've got slightly updated data on people's with the social, emotional and mental health needs. And that data's got fractionally worse since the last time we looked, and again we need to take the full kind of COVID view of that, and we will be action planning against that within the new health and wellbeing strategy, because we've already heard from the public and agreed as a council and with NHS and partners that this is a priority area for work. The data on completion of alcohol treatment is an important marker of quality of that service, and the reason that performance doesn't look as we'd want it to be is simply because within the pandemic, the provider has, if you like, held on to service users for longer than they would otherwise do, because there aren't the same support structures within the community for people to be discharged to. So exactly the same trend is noted within successful completion of opiate drug treatment as well, for the same reason. So as that service moves into a more business as usual approach and we move through the pandemic, that indicator is going to improve, and we're confident that actually the quality of support people are getting from that service has been maintained and it's adapted well to the challenges of the pandemic. And then finally, the estimated diagnosis rate for people with dementia. I think Katie's already given us the exact numbers on that, and we've already committed to some work on that, again knowing that that's become more challenging during the pandemic. So it feels like overall the indicators aren't exactly as we'd want them to be, but I think hopefully what I've